Good afternoon and welcome to Huddersfield Town Hall. Hello, my name's Cathy Elliott. I am Deputy Chair of our West Yorkshire Health and Care Partnership and I am Chair of the Board of NHS West Yorkshire. Welcome to you all. There are people in the room here today who represent the breadth and depth of health and care in West Yorkshire across our 5 places, different sectors and different services. And thank you all for your time today because I know there are many competing priorities for you. We do meet as an integrated care partnership for West Yorkshire every 3 months. We aim to adapt the way in which we meet. Today we're meeting in person. Next time in July we will meet on Teams. But we have a commitment to making sure that the documents and the decision making that we undertake are as transparent as possible. So this meeting today is being live broadcast on our website and will be available on record afterwards. And the documents for this meeting have been available online for a week and will remain on our website for members of the public and people working in health and care to see. Thank you to everyone who has prepared presentations and reports today. As we've done for a little while now, we make sure that each one of our partnership board meetings takes a look at 2 of our 10 strategic big ambitions. And this is a key role that the partnership board plays in making sure that we've got oversight on the delivery of our strategic plans, learning about best practice, and also making sure that we are exchanging that practice and learning from each other as we go along. Today we're going to have a report on our ambition to increase the years of life that people live in good health in West Yorkshire, and also a report on our ambition to reduce suicide by 10% across West Yorkshire, and we'll be hearing a patient story about that later as well, in hearing about work that is going on, particularly in the voluntary sector at this time. We also will be hearing about the new work and health plan for West Yorkshire, and we're delighted Mayor Tracy Braben is with us today and colleagues working with the Combined Authority, and we're going to hear from Mayor Braben later. And also we will have a Partnership Chief Exec report. My colleague Ian Holmes is deputising for our Chief Exec Rob Webster today whilst he is on leave. So there's a lot here. Colleagues, please, as always, I encourage you to contribute to the discussion, be a critical friend to our work, and also to share with us good work that you're doing in your areas. I also want to wish colleagues who've been celebrating Eid Mubarak, Eid Kareem to you. I know there's some colleagues who have been looking forward to Eid and taking part in the celebrations, and we've worked really hard to make sure that our meetings are timed around points of celebration, and also to make sure that we can get as many colleagues as here as possible. We will now, just before we move on to the key parts of our agenda, we've got a lot of leadership changes, and there is a colleague in the room today who is retiring, Len Richards, who is Chief Exec of Mid Yorkshire Teaching Trust. We also, over the next few weeks or so, will be saying goodbye to Selena Douglas, who is moving on from Leeds Community Healthcare to become a Chief Exec in the London system. We have said goodbye to Carol McKenna, our place director for Kirklees, and I understand she had a good farewell recently. And we will soon be welcoming Ed Whiting, new Chief Exec of Leeds City Council, to this partnership. We're delighted that he's going to come and join us, and thank Mariana, who's been deputising for him. And we'll also be welcoming Brent Kilmurray back to West Yorkshire as he becomes Len's successor at Mid Yorks. And to also say this is my last partnership board meeting as chair before I move on to Cheshire and Merseyside NHICB as their new chief exec. And I was reflecting with Ian, though he corrected me, I thought this was the room I was in for the first partnership meeting 5 years ago. It was actually Bradford, but this was the second one, and it sticks in my mind because 5 years ago, this was the last time we had a partnership board meeting in person before we moved in, sadly, into the pandemic. And then what we have been doing together is rebuilding how we want to meet. And thank you again for you all giving your time today to meet in person, because it is important. So, moving on to the main part of the agenda. Today we don't have any questions or public deputations. I want to reiterate that we do welcome questions from the public and members of staff in relation to the agendas, both for this integrated care partnership for West Yorkshire and for NHS West Yorkshire ICB. We very much thank the people that take the time to ask questions about our work. If anyone's interested in recent questions we were asked for our NHS West Yorkshire board, they can have a look at those online, both the recording and the responses that we've given to the And the next meeting of this partnership is on the 15th of July, so we welcome questions from members of the public and members of staff working in health and care by the 14th of July. The next item is the declarations of interest. Colleagues in the room today, are there any declarations of interest in relation to today's agenda? I'm looking around the room and no one is putting their hand up, so that's good. Thank you. And it's just a reminder, colleagues, to make sure that you're keeping your declarations of interest up to date. We have an online portal for declarations of interest, and we know there is public interest in health and care leaders in their work, and that's why we make sure that that is published online. So just a reminder there, and if you want more information, talk to my governance colleagues here. Okay. We now move on to item 4, which is the minutes of the last meeting. This was on the 21st of January, and as you remember, we met on Teams that day. And colleagues, I just want to check for those of you there, is that an accurate record of our meeting virtually back in January? I'm looking around the room. No one's got any corrections, so we will take that as an accurate record. And I also note that we don't have any outstanding actions as well. So thanks to colleagues who have worked on that. Just to reflect the meeting that we had last time, we looked at the English Devolution white paper. It's going to come up in our conversations today, and the Get Britain Working white paper, which very much is related to the work and health plan. We also reflected on where we are in line with the government's 3 missions for health, and thanks to colleagues who have been working on that over many months in making sure that we're ready and delivering already for the new agenda for health and care with the government. But we also await the 10-year plan that will come for the NHS shortly, which I know my colleague Ian will touch on later. So I will leave that there. My colleague Fatima Khan Shah is going to come and join the meeting later on today, so we may hear more about the equity strategy that we signed off at the last meeting, which included hearing from Dame Donna Kinnair. And I know that Fatima is very keen to hear from you all as leaders and from your organisations in how you'll be adopting the equity strategy that we signed off together back in January. So a bit of a plug for the strategy there. Okay. Before we move on to the main part of the agenda, and we are just going to slightly move agenda items round. So in a moment, we'll take item 9, the Work and Health Plan and Programme, and we'll swap that round with item 5 on our CEO report. But just before we get into the Work and Health Plan, I wanted to reflect, as you all know, as health and care leaders, there are a number of things changing at the moment, and many for the positive. We're really pleased to be reflecting on the English Devolution white paper, for example. We are so well set up already with our combined authority and the leadership of Mayor Braben. We know that there are other parts of the country that are not. We're responding already to the Get Britain Working white paper, but we also recognise the announcements early this month of changes and cuts to parts of the NHS, including Department of Health and Social Care, NHS England being brought into Department of Health and Social Care over what we understand is a 12 to 24 month period. And then for us as commissioners for NHS West Yorkshire Integrated Care Board, ICB, that there are required 50% cuts to our work by October this year, and we're just awaiting further formal guidance on that at the moment. So Ian will touch on that later, but Mayor Braben, I don't know if you would just like to say a few words as well, because it does particularly affect our way of working in West Yorkshire, doesn't it? Thank you.
And thanks for adjusting, thank you, the agenda. Unfortunately, I've got a train to catch, so I'm really grateful that you've given me a moment to speak to this, because to your point about devolution being the game changer for us, the opportunity to work in partnership to get better outcomes it was too good to be true. And welcome, Fatima, and one of the queens behind this project, so thank you for coming. So my vision is that we have one of the healthiest workforces in England in 2040, but goodness me, we've got a long way to go. We launched it, didn't we, Kathy, March 10th, together, and it's a unique partnership. that we'd already started the work on in partnership terms when we created the country's first ever creative health partnership, working together and also obviously joining our various boards and so on. So I thought we were ahead of the curve in that way. But it is clear to everybody in this room the health inequalities across our region and the life expectancy gap, it shames us all. And everybody should be, putting their shoulder to the wheel to try and resolve this. And the numbers are pretty stark. Over 280,000 people either not in work or not looking. 1 in 8 of our entire population. And that's 100,000 people are not able to work because of long-term sickness. And it's not people who just can't be bothered. People want to work. There is dignity in work. There is well-being in work. And they are being held back from their ambitions because of ill health. And also, what is particularly stark and very troubling, the fastest growing age group is among 16 to 24-year-olds. So these are young people, I mean, you know better than me, who will not have started a working career and then because of ill health, mental health particularly, don't ever get going. And their life chances are completely diverted because they've just not experienced the world of work and they feel outside of that workplace. And also, really concerning, life expectancy, healthy life expectancy, is lower in West Yorkshire than the national average. Now, as your mayor, I take that personally, and we've got to do everything we can to reduce that health inequality. Because it's not just an economic issue. And of course, my vision to grow our economy, put more money in people's pockets, health is wealth, we all know that. It's also about how people fulfill their potential, the lives they lead, the joy that is in their life, the sense of purpose and well-being. And we owe it to the public, the people that we represent. Now, the way that we've been allocated monies by the government is really welcome. We've got 2 funds, the Accelerator and the Trailblazer. One is to get people into work who are a long way away from work. And then there is a chunk of money to also keep people in work. And you will know how challenging that is. And particularly at a time when, because of the changes in legislation around work, businesses tell me they're anxious about taking people on that might have a health condition that then might cost them more. So that's why my Fair Work Charter is really important. And those businesses, over 200 plus, have signed up to the Fair Work Charter. They want to do the right thing. So we are going to use them in the first instance as like a petri dish of businesses who are in the right space to do the right thing with our guidance and with our support. And I think hopefully they can really help us understand what the challenges are for business, what makes businesses so afraid to take people on that might need hospital appointments and so on. I think it's got a clear vision, the Fair Work Charter. We wanted to deliver something that had carrot and stick. There are other Fair Work Charters across the country led by mayors that are more about procurement. You won't be eligible to procure, to tender for contracts if you're not part of the Fair Work Charter. That's fair enough, but 95% of our businesses are SMEs. And we know that they are the ones that really do need that support. So we're trying to identify where the carrot is, come in, the water's lovely, taking that approach. And I do think this new money, this £21 million, could really deepen that trusted relationship between us. And I'm hoping we only have a year to deliver, and I think, Kathy, you could tell me, is it 1,300 people we have to get into work? Yeah. That's a challenge because that's on top of all the people falling out of work. And we've got to do that in a year. Now, we've said to government, you can't just hold us to the year if the programme hasn't got going yet. There is some flexibility on that, but basically we've got to be bold. We've got to do things differently. We can't just do what we used to do, because that hasn't given us, evidently, the outcomes that we need and we want. So we also have to be prepared to fail. So in meetings with ministers, I have said, there will be things we do that will fail, and you have to not disregard the challenge that you've given us, and encourage us to be bold. And I think one of the really big, impactful ways we're going to do this is by working collectively in collaboration with our partners across the region. But I'm hoping that we make a lasting difference, that this isn't just target-driven and then it all drops away. I have said to government, if this works, we will prove it works. You've got to keep funding it, because we can't just get a cohort into work and then abandon them. But I gather Jen Connolly, my colleague, might also speak to this in some detail. Yeah. So I'll hand over to Jen. Thank you very much, Chair.
Thank you. Just as Jen's joining us, Tracy, sorry, just to ask you, with the health and care changes that are coming through, I know that you have concerns for Leeds. I don't know if there's anything you want to put on public record, or because I know you have a concern about Department of Health, NHS England activities in Leeds.
That's great. Thank you so much for raising that. Obviously, it's a shock to everybody, wasn't it? And on top of the cuts already that have been underway, another 50%. And I don't think it's clear yet what the structure is or what the expectation is, and that must leave people in a very uncomfortable position. Now, I've just come back from a trade mission to Nashville, where we signed a health tech bridge. Nashville is very much like us, a home of health tech and life sciences. And, I talk about as being the home of the NHS. Well, we're the home of the NHS. 300 health and life sciences companies clustering around the largest teaching hospital in Europe. It's our reputation. It's where we've got NHS England, NHSX, all of that resource and talent. So it was very startling, and sadly, devolution hasn't filtered down to Westminster to a point where we weren't even given a heads up, which was, so it caught us on the hop, like I'm sure it caught you as well. So be reassured, I've written to the Secretary of State with a very detailed letter with James Lewis, the leader of Leeds, saying when these cuts come, you must protect digital tech, AI, all of that good stuff that we do, because that chimes with their ambitions. And when Wes was up in the region, he was saying, this is a perfect example of the brilliance of the NHS. When he was looking at an AI project, I think it was it breast cancer screening? Anyway, I do believe he understands what we have to offer. I feel I'm getting the sense from government that they really want to hold on to our strengths. But I have said that the cuts cannot come on our heads, and people in London keep that, unfortunately, if people are going, we have to hold on to the talent. Mm-hmm. Do not get rid of that talent that's going to change the NHS for all of us in the future, because this isn't just about tech or international trade or anything. It's actually about the well-being of the people that we represent and the people in the country. All these innovations are going to make it easier to get people back into work and so on. So I've sent a very detailed letter and had some private assurances, but I'm also seeking a meeting, and that hopefully will come on his next visit to the region. But it was also around the investment zone, millions and millions, 160 million spent in the investment zone in West Yorkshire. A majority of that investment is going to be on health and life sciences and med tech and diagnostics and devices. Then you just don't pull the rug away from under us. So rest assured that the minister's got my letter. I'm also aware that Penny Dash will also get my letter, and we can then go on with further conversations. But I will be your champion for the sector, because it makes us a magnet for investment. And certainly when I was in America, everybody wanted to talk to us because of our data. and the digitisation of 40 years of imaging, born in Bradford. Our data sets are incredible, and we can't throw the baby out with the bathwater. Thank you.
Thank you. Tracy, thank you so much, and thank you for championing us, and we really, really appreciate it. It's this action to make sure that we're raising the profile of our needs and our aspirations, so really thank you very much. And for those of you who don't know, Penny Dash is the incoming chair of NHS England. She's recently been working on health regulation with Department of Health and Social Care, so that's who Tracy was talking about there. Thank you, Tracy, so much. That's great. And that segues then into our colleague Jen Connolly, who's going to talk to us about item 9, because we've jumped to the end of the meeting to talk about West Yorkshire's work and health plan. So over to you, Jen, and then we're happy to take questions and comments from colleagues in the room.
Thank you very much. Thanks for that really helpful overview of the work on our work and health plan. And we brought an update. I was just reflecting that we brought an update to this group at the end of October about the NHS's role in social and economic development, and we talked about the Work and Health Partnership and the sort of groundwork that we'd done collaboratively. But at that point, we didn't know these opportunities around Accelerator and Trailblazer would be a thing that would be available to us. So we talked about the great work that was going on around developing the work and health plan with deep insight from our communities. And I think it's that foundation we need to remember when we're thinking about the programmes that we're looking to deliver over the next 12 months. So as that was developing, we had the announcements through the Get Britain Working White Paper. And that includes both the Accelerator, which is the responsibility of the ICB, £11 million of funding to support people to remain in work who have health conditions, to prevent people from falling into economic inactivity, and £10 million through the Trailblazer, the responsibility of the Combined Authority, to support that work and really reach into the communities experiencing economic inactivity due to ill health. So we see this as a truly collaborative effort in bringing those different pots of funding together under the Work and Health Plan, which sets out the ambition that we have for this year and beyond. So we also think of the Connect to Work opportunity, which is another £16 million through the Combined Authority to support people in this way as well. We've seen real deep system working over the last 3 months, built on many years of relationship development to get us here today with this plan. The Accelerator and Trailblazer plans have just been signed off by NHS England and DWP respectively, with services commencing from today. So it's launch day for the Accelerator and Trailblazer today, 1st of April. The plan, the work and health plan that's been developed through the insight from our communities, from the existing services, and from that ambition for the region, talks about 5 key objectives around strengthening the health and employment and skills system leadership with oversight to inform better decision making across ICB, CA, Combined Authority, Local Authority, and the DWP. It talks about understanding the barriers to and overcoming the barriers for our SMEs, as Tracy mentioned, the large proportion of employers being SMEs in West Yorkshire. So really supporting our SMEs to support their own workforce. It talks about the incentives that might be needed to support more people into work. And it talks about continued backing for our VCSE sector, both as delivery partners and as key routes to engagement with the populations that we want to reach. Finally, we're talking there about network development because we understand how important that sharing, that learning, that working together is going to be to deliver this sustained change that we want to see. So the paper you've got today describes how we're going to deliver that, how we're going to deliver that change through the programmes that we've been able to secure for West Yorkshire. And if I give attention specifically to some of the Accelerator activities for a moment, we can see that the key leads from across places have been fundamental in how we develop those plans. So there's place-specific plans to get us to that target of 1,300 people being supported to remain in work. We've also got within that work a real focus on the health and social care workforce, because we know the importance of that workforce in West Yorkshire, and supporting that workforce to deliver better outcomes to the population gives us a twofold effort to see the impact there. The plan and the work of those interventions that the places have developed has been informed by the data that we have, been developed in line with principles that we agreed across the system, and they're specified in the paper. And it's been funded through an allocation based on needs, so an equitable allocation based on the proportion of economic inactivity due to ill health in each place. That means that the health and social care workforce will see increased capacity and improved connection across health coaching, work coaching and social prescribing. Increased fast-track access to sector-specific services such as supported self-management, professional assessments and first-stage therapies for key conditions like musculoskeletal conditions, cardiometabolic diseases, and that also includes pain management and neurodiversity. They'll also see mental health interventions, including fast-track access, and we will, through this work, we'll also be developing the wider offer, including the workplace promise, which encompasses things like policy, the culture, the training we need to offer, as well as supporting people who are leaving work to leave well. For our wider population, this means that our offers will be targeting people to support them to stay in work, managing their own conditions, feeling empowered to do so, feeling empowered to have conversations with their employers about the reasonable adjustments that might be required. And the types of services that they will see include increasing our rehabilitation offer, so that particular focus on vocational rehabilitation. What are the things that you need to manage your life, to stay well? And that big part of that includes your work and how you manage that and how you feel supported to lead yourself through that. It'll also see an increase in our support for unpaid carers who are disproportionately affected by the impact of the challenges that we've described. We'll also see expansion of targeted offers for working age adults to stop conditions declining further, or to stop people getting additional conditions, so secondary prevention work to find more cases of hypertension, and also things like health check offers being expanded. We'll see more support for people managing pain. We know that some of these, rather than thinking purely with a condition-specific or disease-specific lens, we've really tried to think about the offers that people support their symptoms with. And so pain management is really is common in many disease conditions, and so that change in the way people are supported to manage their pain is really important. We'll also see mental health support, including improved access for talking therapies and further support through individual placement support, or IPS. We've got some waiting well approaches for ADHD and for planned care. We've got links with the VCSE employers offers, and we've got creative health support in there. We're actually really proud that that's quite a diverse and varied set of interventions, because that really seeks to address the diverse range of experience that we heard through the Work and Health Plan insight from our communities. And so that theory of change of many smaller interventions building to a cumulative population health impact is really what we want to celebrate across West Yorkshire. Our target and the focus throughout is supporting those 1,300 people to remain in work who would otherwise have ended up experiencing economic inactivity. And we've heard the negative impacts that will have on somebody's health. And whilst we remain steadfast on delivering that target, we really understand that part of this is also embracing that opportunity to learn, to develop our offer, to learn from each other, to build on that work throughout the year ahead, and really importantly focused on that joint working across the combined authority, the local authorities, the ICB, DWP and other key partners in this. We've got to do things differently and work in different ways with central government as well. And reflecting all of that, I think our governance speaks to that ambition. So at the moment, we've got a joint programme board, which brings NHS England colleagues, DWP colleagues, as well as the key regional and local partners that I've just mentioned. So I think that's well reflecting our ambition, and that governance will continue to evolve over the year ahead. We recognise that there's some really challenging things happening. We recognise there are key risks. They're all documented in the paper as well. But our focus is on that strong vision for change, the clear outcome target, and the partnership working that puts us in the best position possible to deliver. So huge thanks to everybody who's been involved in developing the plan, developing the programmes, particularly our communities and individuals who've provided the experience that they've brought to this to help us understand that real lived experience, but also to key colleagues in the VCSE, in the ICB, the local authorities, Combined Authority, DWP and NHS England, who've really set us up so well for this today, which is launch day. So thank you. Welcome any questions.
Jen, thank you very much, and thank you for your work on this as well. I know you've been working very closely, particularly with NHS England, as well as colleagues in West Yorkshire. I'd really welcome taking any comments or questions. And when you speak, obviously, first of all, turn your microphone on, but secondly, introduce yourself. Just before we go to comments and questions from colleagues and members of the Partnership Board, Jen, I think that your point about the variety of organisations and people involved in this is fantastic. So the event that I went along to with Mayor Braben around the fact that we've got Department of Work and Pensions, DWP, we heard about the success of creative health, both within the voluntary sector and with working in South West Yorkshire, Foundation Trust Partnership, and also to have NHS colleagues. And we had people coming up from London from NHS England to join us as well, alongside public health. I think this is a really great example of ways of working. And colleagues, you'll see in that document about how we're trying to bring a joint committee together, which is what Mayor Braben was talking about earlier, how we're connecting our work together. And this is a straightforward governance arrangement in the way in which we work and try and make decisions and create that investment, which is what Tracy was talking about earlier, to bring that investment into West Yorkshire and our communities as well. So, Jen, thank you. I think Fatima, Eid Mubarak to you. I hope you enjoyed Eid. And then we'll go to Khalil.
Thank you, Chair. I still have a little bit of a halal Eid hangover, but really pleased to be here. Hello, everyone. My name's Fatima Khan Shah. I'm proud to be the West Yorkshire Inclusivity Champion. And I echo the Chair's comments, Jen. I think you've done a phenomenal job on this, and it's really great to see how that has culminated. I suppose my reflections come from the perspective as Mayor Braben talks about putting more money in people's pockets. My job is to make sure that is, equitable and fair for everybody, so everyone benefits from that. And that's kind of the lens of which I'm asking these questions. So the first one is there's a real reference to narrowing inequalities. It'd be really helpful to understand how we know we're making that difference. So what are the measurable, tangible outcomes? And there's reference to inequality impact assessments, and it'd be really great to see what that says and what mitigations we're doing to ensure that it's truly inclusive. My second one is the challenge that we have in West Yorkshire is scaling up is a challenge, but also maintaining that local bespoke need to understand the diverse communities of West Yorkshire is really, really important. So how are we managing that challenge? And hearing a little bit more about the role of the key local players in the joint board would be very helpful to kind of understand that and get that reassurance. And then the final bit was the Mayor and I were at the Fair Work Charter engagement event, and we talked quite a lot about the Inclusive Recruitment Toolkit. That is now available as part of the compendium of resources that we've got for the Fair Work Charter. It'd be really great to understand how we can use that with these organisations to ensure that we are truly inclusive in the way in which we're attracting staff. And then my final reflection is, as a carer myself, the working carers element is so important, but there's no specific reference to the adoption of the working carers passport, which is another thing through the Fair Work Charter we're hoping to really attract people to. So is there a way in which we can join those two up and really maximise the potential of this work? Thanks.
Great, thank you, Khalil. Before we come to you, I think, Jen, there was a number of things there, and I know you and Fatima work closely together, but I think it's if I was playing West Yorkshire Partnership bingo there, I think very much we've got a reminder to everybody in the room to make sure their organisations and leadership teams are using the Inclusive Recruitment Toolkit, which hits a number of our strategic aims and the ways in which we want to work, and the importance of the Working Carers Passport, which is Also, it includes use by our lead chief exec for the system as well. It's an important thing. So, Jen, have you got some thoughts on that? I've bought you some time as well as to get ready for your reply, and then we'll go to Khalil.
Yeah, no, really happy to take those questions. Thank you. So, in terms of the way that we're looking to address the inequalities through the plans, there's a handful of ways, really. I think with the accelerator plan in particular, we have really specified when we've been working with the place leads that as a principle up front, so you can see that in the principles that we set out in the document. So when places have been planning interventions, they've looked at the data about the different conditions that affect their population. We've ensured that places are working closely with public health in place to ensure that you really get that understanding of population differences between the 5 different places. We've brought colleagues in, so we've had a colleague from SREP on the steering group that's helped to shape this work throughout, to give us that voice as well. And I think through the plans, we've also really asked, does this have a direct impact on inequalities, so that we can go through those interventions and see exactly which ones are targeted in that way, as well as the overall approach looking to address inequalities that way. So there's a number of different ways that we're seeking to deliver on that. In terms of the representation on the programme board, we've got the local places are represented and also the local authorities are represented. And we had a brilliant session just last week, where those presentations came forward as one thing. So Kirklees presenting together on how the work that they're doing collaboratively at place will deliver the Accelerator, Trailblazer and Connect to Work programmes cohesively for the communities of Kirklees, as an example. In terms of the inclusive recruitment toolkit and also the working carers passports, absolutely. We want to grow, spread, share that sort of practice. And so for our own workforces, that's through the health and social care focus and the kind of workplace promise efforts that we're looking to spread those good practices. And as you yourself recognise, the Fair Work Charter, working with those businesses, that's the other way that we can spread that good practice, as well as some of the other routes to the business community that the Mayor and other colleagues have got to help us spread that even further. Thanks.
Great. Thank you very much. Over to you, Khalid. Would you introduce yourself?
Thank you. Hello, I'm Khalid Naeem and I'm a GP in North Kirklees, and I'm also chair for Clinical Care Professional Forum, and I'm plant care and plant care lead for Kirklees. I think thanks for the presentation, and I think we've got at least a direction to travel in the right direction. I think from the general practice point of view, when we see people who are ill and then who are not going to work and who are on sick leaves, a lot of times it's due to stresses at work, and where you have mentioned something about cultures at work, and I think that's something which definitely needs to work on, where we've got friendlier atmosphere at work, and how people can be accommodated at work, and less stress at work, and looking at people's difficulties, stresses, and addressing some of them. My experience and some of my colleagues' experience, is that once they've become ill, it's very comfortable for them to remain ill for longer periods of time. And I highlighted right at the start that you're asking for a sick note, and I'm sure that in 4 weeks' time you say that you'll still be sitting in the same place. And something which we need to do, either locally or nationally, where there is another tier of assessment for their for their illness, apart from outside the GP, some independent source where people can be assessed and then rendered fit or not fit for work. In my opinion, you've mentioned carrot and stick, type of approach. I think carrot and stick is good for employers, but also carrot and stick should be for a patient, for a sick person as well, employee as well, so that they've got some incentive, but also at the same time there is some sort of push for them to return to work and some attraction to get back to work. It could be employer-based assessment. It could be health-based assessment. And the other thing I also wanted to say that when we were talking about wider determinants of health, this morning we were in West Yorkshire Clinical and Care Professional Forum, and when we were talking about hypertension management, we were very pharmaceutical, based, planning. And one of my colleagues, Peter Davis from Halifax, he highlighted that we as clinicians, doctors, nurses, healthcare professionals are very pharmaceutical based, and we need to look at other things which improve health, activities and exercise and those things. And we know that there are cuts to council budgets which are affecting our ability to deliver on some of these things. Health. Sports centres are being closed, or services are being reduced, and subsidies are being, so we need to look at that, and especially for people where we're talking about reducing health inequalities, that we are not doing it in places where people are, deprived, especially deprived areas. So these are messages which I wanted to bring across. Thank you.
Thank you, Khalid. Jen, would you just respond on that? I think there's a number of things there. There's practicalities on supporting people back into work, as well as the wider activities beyond the likes of the NHS, for example.
Thank you, and it's great to hear your advocacy for that sort of working in general practice as well, which is really what we need to see develop even further through the work of the integrated neighbourhood teams. So I think the connection with this work and that development, go hand in hand, thinking about how we work with people in our neighbourhoods as a collaborative and wraparound service, essentially, that takes into account people's living, working, social circumstances, as well as the health conditions they're presenting with. So I think there's a few things there. They touch on culture at work, and we've heard about the Fair Work Charter and the sort of people promise, the way we want to work with our employers to understand and develop those good practices to make more good work in our community, so that fewer people are experiencing the type of stresses that you described. And I think that the role of patient empowerment as well is really important, and that's quite evident in some of the vocational rehab work. Encouraging, empowering people to take responsibility for their condition and managing their condition well in their lives, which is an important part of that work. So that's why we've sort of focused on that vocational rehab across West Yorkshire, really growing those skills. But the engagement with primary care is key, and particularly looking at opportunities to intervene at sort of second stage, something that we're testing in a few places as well. So all of the things that you've touched on are really sort of key components of this work. Happy to have further discussions about how we can take that forward, particularly with sort of, primary care colleagues, but I think that there's key links into existing work as well there. Thank you.
Great. Okay. Sean, to you, would you introduce yourself? And I'm also interested in the role of mental health services and employment as well, because they've got a long track record, haven't you? So thank you to you.
Thank you. Sean Rayner from South West Yorkshire Partnership, NHS Foundation Trust. Thanks, Jen, for your presentation. I think you alluded to this in your presentation, but as the Chair's referenced, there are a number of projects and initiatives already in situ, the individual placement and support work that many trusts undertake, and we do in South West Yorkshire Partnership Trust, which is an evidence-based programme to support people with severe and enduring mental illness into employment, and sustained employment is really important. Lens Trust at Mid Yorks operate Project Search, which supports people with learning disabilities in employment, and it provides some excellent support. So I think, in my mind, I'm thinking that there's, in the governance framework, there's a need for coordination to ensure we're not duplicating, we're targeting on those populations that really need this support. And there's a wealth of experience in the NHS that can support that work. So it's just a plea to draw on that as you go forward. Thank you.
Thank you. It's great to hear, because we've met recently with the lead programme director for the Mental Health, Learning Disability and Autism programme to really look at how we can connect that learning from IPS that's already been well delivered across West Yorkshire, because so much of the Connect to Work programme is around IPS. We really want to make sure that we're kind of really bolstering that across West Yorkshire, and it's a particular model, isn't it? And we want to kind of make sure we're learning and looking for where that provision is already in place across West Yorkshire. There's some minor differences in the target sort of groups that work is looking to reach through Connect to Work, but also the existing IPS provision. We did some mapping to look at the current sort of suite of interventions that exist, and it's a huge and complicated map of all different things. And so there's something about how we navigate that and how we expose that and how we kind of learn from that as well. So I think I really sort of support what you're saying. Yeah, happy to learn. Thank you.
Jen, would you just explain for anyone watching the meeting what is IPS?
So it's individual placement support, and it's a very defined intervention that works with people to support them into a placement of work, and the wraparound support that's put in place to support someone to stay in that placement of support. It's what's called a high fidelity model, so there's a lot of steps that have to be done in a particular way, in a particular order, and it's well audited in that way. So it's a very prescribed intervention. So there's definitely a place for that. But I think what we've seen through the opportunity through the Accelerator and Trailblazer is to really reach cohorts and target populations who wouldn't otherwise meet the quite strict definition that's required for that work.
Great. Karen, to you, would you introduce yourself?
Yeah, hi everybody, I'm Karen Jackson. I'm the Chief Exec at Locala and the Sector Lead for Community Services. So I'm putting my social enterprise hat on. I do wonder whether there's an opportunity to do things more creatively. So if I think of some of my colleagues nationwide, they're doing some really creative things from a social enterprise point of view, opening garden centres and employing people with mental health difficulties, which generates income that's reinvested into their communities. And I just wonder whether we're using all of the flexibilities that we have, not just in the statutory body, but beyond. And actually, that's based in people's places that they live. And if I think about my colleagues, they understand where people live because they go and work with them every day. So I just wonder whether we've got a bit more we could perhaps pop in and perhaps we could have a conversation.
Yeah, I really welcome those conversations. We've tried to engage quite widely on the development of this, and a large proportion of I can't give you the number right now, but a substantial proportion of the interventions do work through the VCSE and also through the Trailblazer plans to really deepen that engagement with the VCSE. So I think there's some great learning from stuff that's already happened, but I'd love to hear more and what we can do. Thanks.
Great. VCSE, Voluntary Community and Social Enterprise Sector. I just want to invite my colleague Ian Holmes to talk about integrated neighbourhood healthcare. For those of you in the NHS, it's in our planning guidance for 2025-26. Very much links with the work that you're doing, Karen, in leading across the system with the Community Services Provider Collaborative, which is a very broad group of people and organisations that have come together. But Ian, how does work and health link with integrated neighbourhood team working? And if no one else has got any more comments after this, we'll move on to the next item.
Yeah, thanks, Kathy. Ian Holmes, Director of Strategy and Partnerships, Deputy Chief Executive. So thanks for the presentation, Jen. And as you said, there's been a huge amount of work done in quite a short period of time here, and I think you can tell through the conversations that we've had, there's a real energy and enthusiasm to get involved. And I think it's one of those things where you can see with the programme board that we've established, we've got a really broad cohort of people working together, which has been really, really good. I think the other thing that's noticeable about this piece of work is that we've done it in quite a West Yorkshire way, haven't we? So we've got a place-based model of delivery, we've got a really strong focus on inequalities, and we're bringing in the VCSE and other partners to try and deliver in a holistic way, which is really, really good. I think there is a really clear connection to the work on integrated neighbourhood health. It was signalled in the planning guidance that this needs to be a real priority for places moving forward, and how we integrate services to meet people's needs holistically is kind of what it's all about, working with NHS partners, but also with the VCSE and other partners. So clearly how we support people into healthy, into good work to improve their health is a key aspect of that. The final comment that I just want to make, Cathy, is I think we need to be really delivery focused on 1,300 people. I think Tracy's mentioned that 1 year is great, but it's probably not enough to deliver the sustained change that we need. And I think we need to be demonstrating back to government with the evaluation work that we're doing that this can deliver sustainable benefits for people in West Yorkshire, so that we can continue to be back to do work like this.
Jen, thank you so much. Thank you, colleagues, for comments and ideas, because no one was criticising the plan in any way, just wanting to make it richer so that it can be much more effective and connected. We've got suggestions here of improved work with primary care, aligning with integrated neighbourhood teams and community services collaborative, continuing to work effectively with the voluntary community and social enterprise sector. A reminder to everybody on that, promotion and use of the working carers passport, inclusive recruitment toolkit as well, and to support you as well. And we note the publication and launch of the Work and Health Plan. I encourage those of you who are leading boards in our systems to take that into, whether it's your Health and Wellbeing Board or your NHS Provider Board, for example. We note and support the collaborative approach, and we support these plans on the point that actually Mayor Braben, Jen and yourself have made in about that, supporting 1,300 people in our communities through our place-based working. So Jen, thank you for your work. It really appreciated in this new way of working. Thank you, Tracy, as well. Okay. The other point I was going to make as well is just a reminder on the Fair Work Charter that links with that. We've got lots of tools in our health and care partnership which we hope are useful to you as leaders, to your organisations, to your place-based partnerships. Okay, so we are jumping around the agenda today if anyone is trying to follow this in the room and also watching online. So we have now completed item 9, which was looking at our health and work plan. We're now going to go to item 6. We're going to take the Chief Exec's report at the end of today. But item 6 is our patient public voice, which we always have within our meetings, which give us a moment just to reflect on the importance of us focusing on the communities and the local residents that we serve, but also then aligns with reports that we're receiving on our progress in delivering strategic plans. So today's patient public voice links with our item on our ambition to reduce suicide by 10% in West Yorkshire, and we're going to invite Ros and Lisa from the Suicide Bereavement Service at Leeds Mind to talk to us about their ambition to reduce suicides across West Yorkshire and make sure that we are providing compassionate and supportive care. I'm just giving them time to join us. Would you introduce yourselves, Ros and Lisa, and we'll welcome hearing from you. And what we're going to deliberately do then is take a break after we've heard from Liz and Ros, just Lisa and Ros, to give you time to reflect on that, and then we'll come in to hear from colleagues in public health, Em and Rebecca, on our report and progress. So over to you. Welcome. And when it's on red, that means they can hear you.
Lovely, so that was a good start. Don't know how to work with technology. So my name's Ros Doherty. I'm the service lead for the Suicide Bereavement Service at Leeds Mind. And just to keep you all on your toes, I've not brought Lisa, I've brought somebody else.
Okay. Hiya, I am Rachel Walmsley and I am Leeds Mind Suicide Bereavement Service Senior Post-Pension Practitioner.
So I'm going to talk a little bit about why we exist and what we do, and then Rachel's going to speak from the lived experience point of view. So this is a much more formal meeting than we were expecting, so please bear with us. I'm glad I wore a shirt, but I didn't know it would be recorded or mic'd, so if I'm a bit robotic, please bear with me. But I just wanted to start by talking about numbers, and before I talk about numbers, it's really important to recognise that behind every number there's a person, there's a friend, there's a family member. So it can feel a bit clinical talking about numbers, but it does serve a purpose. But in 2021, There were 5,583 registered deaths by suicide in England and Wales. 589 of those were registered deaths by suicide in Yorkshire and Humber. For each person we lose to suicide, significantly affected by one death is 135 people. So if we scale that up, in 2021 we had 79,515 people directly impacted by a suicide in Yorkshire and Humber. So we've got a lot of people out there who need support. So I just wanted to kind of give a little bit of context as to numbers and why we're here. So at Leeds Mind, the Suicide Bereavement Service is a post-vention service. And post-vention refers to activities that reduce risk and promote healing after suicide. And this can include challenging attitudes, one-to-one support, reducing stigma, delivering groups, raising awareness through outreach, training and want to know more sessions, and advocacy. So why do we need post-vention? So bereavement by suicide leads to greater instances of complicated grief, concurrent depression, post-traumatic stress disorder, suicide ideation, and if left untreated, can lead to prolonged suffering, negative health outcomes, and impaired functioning. And we obviously don't want that for any of our communities and citizens. So we also know that people bereaved by suicide are 1.6 times more likely to have suicidal thoughts, 2.9 times more likely to have a plan for suicide, and 3.7 times more likely to attempt suicide. Feelings of complicated grief often result in the reluctance of survivors to seek help or involve others in their grief process. In turn, this leaves survivors feeling isolated, stigmatised, and with limited social support. So by default, post-vention becomes prevention. I've already touched on this, but I think it's really important to recognise that people impacted by suicide are more likely to experience serious social adverse consequences. And by that we mean relationship breakdowns, unemployment and financial worries. They're more likely to engage in high-risk behaviour, so this can include drug and alcohol misuse, self-neglect and problem gambling. We know already that people are more likely to experience suicide ideation. And they are the people bereaved by suicide are the most likely group of people bereaved to experience PTSD. We know people are more likely to attempt suicide, and we know they're more likely to die by suicide as well. And there's also wider societal considerations we need to consider when people have been bereaved or impacted by a suicide. Stigma is a massive issue, so stigma can come from personal belief system, tensions within the family, stigma from local communities, social isolation and cultural and religious views. We also know that people who have been bereaved by suicide have to go through an inquest process, which is often quite distressing for lots of people. So there's a misconception that the inquest is going to give people answers. There's often a lack of sensitivity due to the formal process. Often people are referred to as the deceased, and so hearing your loved one referred to as the deceased person can be quite upsetting and traumatic. There's often delays in the inquest process, and the public nature of proceedings can be very, very difficult for people to have to navigate and handle. On top of that, there's often press and media attention. So personal information is often revealed, distressing descriptions such as this grisly discovery and the nature, the method of the death is often shared. Sometimes people find out online about the death of a loved one before police have even had a chance to notify them. And often the reporting is sensationalised. So I think it's fair to say that's why we exist and why we're needed. So I'm just going to really quickly touch upon what we do, and then Rachel's going to talk a little bit about her own experience. So we are a peer support and a lived experience service. So all of the team members, apart from myself, have lived experience of being bereaved or impacted by a suicide. And this allows us to support individuals and families in the following ways. Staff are able to demonstrate genuine empathy, normalise feelings, instil hope and empower people. We provide a safe space to talk about feelings and worries. We reduce isolation. We provide mutual support. We're happy to have conversations around method or injury where it's pertinent to the individual and it's important. We don't do that with everybody's standards. We're able to understand the impact of a suicide bereavement. Our service increases confidence and self-esteem. We provide a source of hope and optimism. We allow for working with people who get it. So you're sat across from somebody who gets it, you don't have to explain because they've been there themselves, which in itself is a really powerful tool. And we help the bereaved find their own voice. We're not there to speak for them, we're there to empower them to find their own voice. So what we do, we offer timely compassionate support to those bereaved by suicide across West Yorkshire, and we support people no matter the length of time since loss. So they could have been bereaved 2 days ago, 2 weeks, 2 months, 2 years, 20 years. If somebody's telling us they're ready for support, we will support them. We offer one-to-one support delivered across 6 sessions. We offer family support. That's where we work with the whole family support unit, including young people, and we will have additional sessions for the parent, carer or guardian or the young people if that's needed. We work with staff and students after a suicide, so we may go in and do sessions for staff, we may do sessions for the pupils, however they may need that too, or we may do both in fact. And then we also do a lot of employee support, so if we know that a business has been impacted by suicide, again, we can go out and we can offer group support, and then anybody at one stage can come in for one-to-one support. And in Bradford and Kirklees, we have a family support worker. They will work with very young children, and then everybody else in West Yorkshire will work with 11 plus. So that's what we do. You've heard my lovely dulcet tones far too long now, so I will pass over to Rachel.
Okay, so I'm going to obviously speak about my personal own lived experience. As Ross just said, that every single member of our team does have that lived experience, and it's absolutely vital in the work that we do, especially working with children and young people. So my lived experience is that we lost our family member to suicide coming up to 7 years ago now. Luke was only 25 when he took his own life. Sorry if I get emotional, but I'm talking about my loved ones. So, but yes, so he was 25. He had battled with his mental health probably about 2-3 years. He was a professional rugby player, a Kirklees lad. He lived local, yeah, he just found it very difficult, just life in general. Lost his contract with Wakefield with his rugby, and at that moment, life just took a real downhill turn. And in July 2018, after actually 10 attempts to take his own life, Luke did take his own life and left behind a 1-year-old little boy. So our family was completely devastated, as you can imagine. And I can remember the day he took his own life at the family farm. And I remember on the day going to the police, who were absolutely excellent in what they did and trying to support us. But I sort of said, what happens now? What happens here right now? And they just handed me a leaflet. They handed me Help Is at Handbook. And I was like, no, what happens? And we said, oh, we'll take Luke's body away. And I was like, no, what happens with the family now? There was just sheer devastation, you can imagine. And they said, we're sorry, there's nothing that we can do, and just give me that booklet. I knew at that moment in time that every single member of our family was completely devastated, and our world would never, ever be ever the same again. And I have another part of my life, which is actually another charity based within Kirklees, and I was going out speaking out about how that support is massively, massively needed in Kirklees right now and across West Yorkshire, as we didn't have anything. We didn't. And there was breakdowns. Ross was just talking about it, but I can say from personal experience, there was massive breakdowns between our family because we were all grieving in our own way. And I know for me personally, for my sons, I was sort of that person who was trying to keep everything together and didn't deal with my grief either. And 18 months later came crashing. So that support's really needed, and I was sort of speaking about this and saying, please, can we have something? Because I just knew what had happened to my family. 3 years later, the funding came for the Kirklees family worker, and I was successful in getting that role. So I've worked within Kirklees, supporting children and families and young people within the area. And as Ross just said before, it's when a young person sat in front of you and a child says, you get it, you understand, because that lived experience is absolutely vital in what we do. Because as an adult, I know I was left with so many of the what ifs, what's the question, why, what happened, all those. But those children and young people have that too. And they didn't have a safe space to come and speak and talk about that. So getting that funding within Kirklees and being able to offer that safe space to the children and young people and families was just amazing for me as well, knowing that how much we needed it and how many other people needed it as well. And it's also sort of, you know, within Kirklees and across West Yorkshire, we are not just supporting where it's the adult that's taking their own life. We're supporting those where it's the child or young person that's taking their own life. And that is something that we don't necessarily talk about too much. We sort of presume it's the adult and the family. But I'm seeing that more and more often. And when we're saying about going into schools, that's when we're going into schools, because there's a young person that's taken their own life as well. So those young people and their voices is, you know, really important to us at Leeds Mind Suicide Bereavement Service. And just before Christmas, we did a co-production with young people that we have supported within the West Yorkshire area. And there is a film now of their voices that's out there. I know we haven't had time, obviously, to actually show the film today, but I'd just like to read a quote, if that's okay, from one of the young people that was actually part of the film. I worked with Leeds Mind Suicide Bereavement Service after my dad took his own life. My mum was always there for me, but I felt still alone and trapped in my own mind. I felt more relaxed knowing I had a space I could be more open with my mum and sister without struggling to bring my dad's loss up. Leeds Mind is a safe space that has really helped me through my experience. Leeds Mind were absolutely incredible with helping my mum and me and my siblings to be able to kind of navigate through the grief in a really, really healthy way. And that was Leah who spoke on our film. So if you do get a chance to have a look at the film, please do, because it is the voices of the young people within our area who massively need that support.
Ross and Rachel, thank you so much. That was a privilege to listen to what you wanted to share in terms of the service, and thank you, Rachel, for sharing your experience. It was very powerful, and you get to say it in front of all these leaders, including the Mayor, to share your work as well as what's important in terms of health and care. Is there anything that anyone would like to ask? I think we're all grateful. It's always a humbling experience. You can see people's faces in the room here. This is really important as leaders. Then after our break, we will then look at what we need to do together to reduce the suicide rate in West Yorkshire. But the point you're also making is sometimes you need Leeds Mind as an alternative way rather than an NHS service. You need a voluntary sector service or a way of working differently to support people at a time of need. And I love the fact that someone said Leeds Mind is a safe space to navigate their grief. I think that's very, very powerful. I don't know, Tracy, would you? Yeah, thank you.
Just want to say thank you. That was really compelling, and also for the work that you do. I was at an event which was the remembrance of COVID, a 5-year anniversary. Whilst it is different circumstances, there were a lot of people in the room who'd experienced loss and grief. And I met an organisation called the Good Grief Cafe, which you get just a card where you could find out where your cafe is, your nearest cafe. I wonder if there's anything that is similar that we could do around suicide. Obviously, your point is dead right. Where do you go when you're facing the worst experience in your life? But also subsequently, as the years go by, you know, it does come back to you, as you've said, you know, that you sometimes you're surprised, I'm sure, by grief just hitting you out of nowhere, and maybe a Good Grief Cafe might be a good space to go to. But would that need a specialism around suicide? I would imagine so. But I just wonder if that's something that maybe Fatima and I could take away and just look at how we can be helpful in that space.
Yeah, obviously we want further funding, we want to be able to continue. I think cafes are a great idea, perhaps for people to then find out about us, because the support we offer is so specialist, because it's that peer support, it is that lived experience. We do run groups and we try and run socials, because we also recognise that everybody wants to come and just have a very intense 6 sessions. So we would always advocate for further expansion of what we're already doing and diversifying, so we can kind of meet as much need within service as possible, because we have got the specialists within there.
Before you go, we have some other colleagues who want to ask questions. And again, this is your opportunity to talk to senior leaders in health and care. So Susan, and then we'll go to Kim. Would you introduce yourself?
Hi, I'm Susan Hinchcliffe, leader of Bradford. Thank you for coming and sharing your experiences. It is a really emotional subject, isn't it, that as leaders of the place, and we all come across on a hopefully not too frequent basis, but it is devastating for the families that it impacts forever. And obviously in this day and age, there's so much negativity in the world, isn't there, really? It must impact on people, and that is a concern really going forward, isn't it? How we support people to live in a positive environment when they see so much stuff on social media, on the internet coming towards them. But I just wondered, from your experience, is there anything that you see us as public agencies doing which we need to stop doing, or we need to do better? Because there's loads of stuff in this paper, that really good work that's carrying on. But you mentioned coroners there as well. There's a coroner in Bradford, of course. There are probably things that we can improve on if some of the impact of how people are acting, or the processes or the bureaucracies, are actually negatively impacting on people at this time. And it may be something you need to troubleshoot for us, and to say, these are the things, you could stop doing now to help the situation of people in that circumstance. And I'm sure everybody would be happy to try and take those actions away and do something about.
Thank you, Susan. That's great. I know, Ros, you might have a response now, but also what I would say is, if you think of anything over the coming days and weeks, please let us know. But I don't know if your immediate response is.
So I don't know how much everybody knows, but we've got the real-time surveillance in place. So when there is a suspected suicide, the next of kin and witnesses are contacted. And I know there's question marks around that funding. For me, if that could continue, I feel like I'm here just begging for funding. But I'm only here once. That's a really integral part of our service, because beforehand we're reliant on word of mouth, and word of mouth does get us quite a lot of referrals. If we support one family member well, they're going to pass that on, and we're more likely to see people. But that real-time surveillance post means that people are contacted within a week, a couple of weeks of being bereaved by suicide. They're aware of us from the get-go. That's not always going to manifest into referrals, because we do know people access support at different times. So somebody just knowing we exist is what makes the difference for them to then access us a month, 2 months, 12 months down the line. So I think further funding for that, or a continuation of that role, is integral really for us to be able to reach people. Otherwise, we sometimes are reliant on seeing things in the news and then trying to do sensitive outreach. I'm sure some of our commissioners are looking at me, they're thinking there's other things I could mention. I can't think off the top of my head, but definitely, there are lots of things. Reporting, pressure on news agencies not to report insensitively, drones going up and filming oversight. There's lots of things that really negatively impact people. But if we can reach people in a timely fashion after they've been bereaved, for us, really makes a big difference. So that role is integral, really.
Ros, thank you. And as I said, if there's anything further you think about, Rachel, do you want to come in? Yeah.
Obviously, that lived experience I'd like to say, just regarding like the drones, we experienced that, and we was told because it was in a farm, and obviously it's a public right of way, and the police that was the first things they were said, we've put a police car at the top, because there's going to be press and the media trying to come down and take photographs and things. And as a family, you imagine at that moment your life is just absolutely devastated, and you have got the media coming down, and obviously social media with what people are putting on. So that is definitely something that really does need to be massively addressed, because we've experienced it firsthand.
Thank you. And you are speaking to both NHS, voluntary sector and local government leaders here. So I think that is something to take away. And I'd also, Susan, your point on the coroner's court as well. You made a point earlier, Ros, on the delays that go on with inquests. So I think these are, bring the list when you have a think about it. I'm sure you'll think of something on the way home. Last comment we'll take, Khalid, we'll come to you in a minute. We'll go to Kim, and then we'll go to Khalid, and then we'll finish up on this. But thank you. Kim.
Thank you. Hi, I'm Kim Shuttler. I'm the VCSE lead for the ICB, but I'm going to wear my mental health hat for this one. I used to be the Senior Responsible Officer for Suicide Prevention in the ICB, and I also run a mental health provider in Bradford. Thank you for all your work and everything that you do every day. Thank you to suicide prevention colleagues from the ICB who've pulled the paper together. Last time this item came to Partnership Board, what I observe is that the asks are really similar actually. We have identified suicide prevention across West Yorkshire as one of our big ambitions. And I'm really proud that we do that in West Yorkshire, but I think we have to be collectively clear that this isn't a national ambition, and since I was the suicide prevention SRO, the funding for suicide prevention has significantly depleted. We lost our national funding for that. So therefore, colleagues have worked very, very hard with the resources and in the current climate that we have to make this work stretch as far as it possibly can. But I think there's a very clear message that comes through in the paper about the challenges of sustainability in this work, and that work like the work that Leeds Mind is doing and other organisations that have previously been run through the suicide prevention programme beyond are no longer sustainably funded. So I think we've got to understand collectively that we have a choice to make alongside our very, very difficult choices we're making across all our programmes about this as a collective priority. The problem with suicide prevention is it is everybody's responsibility and nobody's responsibility, and therefore it's very easy for it to sort of fall between the gaps in terms of what action that we take. But I think there's also some clear asks in the paper about what we could all do as system leaders, even within our own organisations as large employers. So I think we really need to consider that and ask everybody in this room to think about what we can do to make sure that this doesn't get worse, because we're very aware that in the current climate that suicide rates will be going up, not down. Thank you.
Great. Kim, you've started our focus into the paper that we'll take after the break, but thank you. And thank you as always for your challenge. I know when you're, as a board member for NHS West Yorkshire as well, it's right to challenge us and right to challenge the progress that we need to make. And I remember having the discussion about this area of our work and needing more sustainable funding for it as well. Could I ask Khalid then Emily to give us some brief comments, and then we'll finish up and we can take a break and then come back to the main paper. Khalid.
Thank you. I think you're right that Kim is right that it's everybody's business, but it's nobody's business. And when it becomes everybody's business, then nobody is made responsible for it. One of the things which I would think that it's a wonderful service, and I think we need to make sure that more and more people know about it. And I think from primary care perspective, I would think that we have got social prescribers in working in practices which are very centrally placed to signpost people to your service, and then neighborhood teams and then community champions. They need to be brought into this, and if your service on directive services, it will be even better for all of us. Thank you.
Thank you. And before you leave, I encourage you in the break to talk to colleagues from primary care. There's a few people here representing primary care if you want to talk to some GPs. Over to you, Emily.
Thank you. I'm Emily Parry-Harris, consultant in public health at Kirklees, and here for Steve Mawson today. Thank you for your presentation. I just wanted to speak in support of two of your points, very briefly, because I'm between people and a cup of tea. The real-time surveillance, it is so important to us in public health. I'm not sure that quite comes through in the paper. There's a huge amount of information in the paper, but if there is one thing that I wanted to pick out, that the data that it gives us, the ability that it gives us to notice quickly that something's happening, the ability it gives us to give families the support immediately that they need it, for us to be able to notice where there might be something that looks a bit like a cluster, because we know there's a really significant contagion effect relating to suicide. So I just wanted to pick that point up. And then I wanted just to pick up and reiterate your second point about the importance of responsible press reporting. It really, really matters. And people in this room who can help us do that well with our local press and with our national press, to help them understand the impact that it has if you've described place of death, or you've described method of death, or you've described any of the what may appear like inconsequential details, but really matter to those people who are bereaved, but also give people information about how and where, and if there are people who are already vulnerable, we have a responsibility to make sure that that doesn't happen. So thank you for both of those points, but I particularly agree with those two.
Thank you so much. So we've got, and we'll come back to this, but there's a whole campaign on real-time surveillance, which I know Rachel and Em will talk about later in the paper. The management of the media, and I think this is something for example, our local government leaders and working with Mayor Braben to see what we can look about that point about responsible press. Reporting, continuous and sustainable funding and engagement with breadth and depth of health and care, but the point that Khalid made about primary care and also in the NHS, we need to design and deliver integrated neighbourhood health care, and I think this is a really key point in making it everybody's business. So, Ros and Rachel, thank you so much. It's really a privilege to hear from you about your work and your experiences, because it's incredibly powerful to help us with our decision making today, and you're very welcome to stay for the next section where you'll hear leaders talking about the next phase of our plans as well. But thank you. Thank you. So we're going to take a break now in the meeting and come back in 10 minutes' time. But thank you, colleagues, for your contributions. Welcome back to the second part of our meeting, our West Yorkshire Integrated Care Partnership meeting here at Huddersfield Town Hall. Hello, my name is Kathy Elliott and I am Deputy Chair of our Integrated Care Partnership and deputising for Councillor Tim Swift today. If you've been following the meeting, we have a gathering here of health and care leaders, the breadth and depth of our health and care partnership across our 5 places and a variety of sectors. We're now looking at item 8 on our agenda today, which is our ambition to reduce suicide by 10% across West Yorkshire. This is one of our 10 big ambitions as a health and care system, working across the breadth and depth of the NHS with local authorities, health and wellbeing boards, the voluntary community and social enterprise sector, and all other agencies working in health and care. We are delighted to welcome Em and Rebecca, who are going to talk to us about the progress in our work on suicide prevention, and it very much strongly links with what we heard from Ros and Rachel earlier, who were sharing their work and experiences from the Suicide Bereavement Service at Leeds Mind. So I'm going to hand over to Em and Rebecca. Would you introduce yourself, and over to you to share some opening remarks, and then I'd welcome hearing from colleagues in the room.
Good afternoon. I'm Becky Elliott, Public Health Manager at Kirklees Council. I'm also one of the Senior Responsible Officers for Suicide Prevention across West Yorkshire as well. I'll let Em introduce herself.
Afternoon everyone, I'm Em Irving. I am the Head of Improving Population Health, or one of the Heads of Improving Population Health now, at the Integrated Care Board.
So thank you for having us here today. Thanks for inviting us to give this update. Just before I begin, I'd like to give a thank you to Ros and Rachel for their update around the work that the Suicide Bereavement Service do. We couldn't do the work that we do without that service, so really great to have the opportunity to share what they do with all of you here today. The update that we're going to give this afternoon builds on previous conversations that we've given around our shared ambition, as we've just mentioned, to reduce suicide by at least 10% in West Yorkshire by 2027. And as has just been said, it is one of our top 10 big ambitions. We do know from our recent figures in 2023, we've sadly lost 257 people in West Yorkshire to suicide. And as was highlighted earlier, 135 people are affected by each and every one of those deaths. So that equates to just under 35,000 people in West Yorkshire that have been impacted by suicide. What I'd like to do today is give a little bit of a flavour as to the suicide rates and do a little bit of reflection back in terms of the support that the West Yorkshire ICB Suicide Prevention Programme has given to us at Place. And then I'd also like to just share a little bit about some of the work that we do at Place in relation to the local authority work. So our West Yorkshire suicide rates are higher than the England suicide rates. That won't come as any great shock. But what we do know is that when we look at our suicide rates in West Yorkshire, what that does is it does mask what is happening in each of our local authority areas. So whilst it's important to recognise the suicide rates and the trends that are happening, what we also need to do is look a little bit deeper at each of our local authorities to really understand what's different between our local authorities, what's unique to our places. And that's what each of our local authority place leads that aren't here today do such great work on. So some of the significant regional pieces of work that really add value and have added value to us at local authority over the past 12 months and beyond have been things such as the development of our suicide prevention website across West Yorkshire. That didn't exist before, and now it's a real central hub of information for anybody who is starting to struggle with their feelings or thoughts of suicide. It's one place where they could go, and there's a wealth of information on there and a need urgent help button. As has already been mentioned, the funding that we've been able to access through the regional programme for the likes of the Suicide Bereavement Service have been invaluable. We've had things such as a Check-in with Your Mate campaign, which has actually won awards, primarily targeted at our middle-aged men cohort, which is still our biggest population group, our biggest sort of risk group for suicide. We've also had a Champions programme launched across West Yorkshire, which is trying to increase the number of suicide prevention champions that we have across West Yorkshire. Not just sort of signing up tokenistically, but actually asking people to pledge, what are you going to do in your organisation as a result of being a champion? So go away and do something with that pledge and try and make some sort of tangible action. And we've got over 400 champions now. And we're looking to really strengthen that role going forwards over the next 12 months as well. And one of the things that it really does, which is brilliant, and this is something that I'd encourage you all to think about, is that the Champions role is all about encouraging people to access the Zero Suicide Alliance training. It's between 20 and 30 minutes long, it's completely free, and we just recommend that anybody, regardless of role, should do it, unless you've been recently bereaved by suicide, in which case we would obviously try and give a bit of a word of caution there to maybe not undertake it at that moment in time. But it's very accessible and it really just gives people the confidence to ask those questions. We mentioned about being in work earlier and being stressed. Are we encouraging our staff and our line managers to ask questions when they're noticing behaviour changes? Are we encouraging staff to have the confidence to say and ask, are you feeling suicidal? Do you have thoughts of ending your own life? And we need to be that direct, really, because otherwise opportunities will be missed to intervene. And then the other final thing that's really added value to us at Place from a West Yorkshire perspective is the real-time surveillance, the RTS role, which obviously we've already spoken about, but just as a public health manager to talk about the impact that has given to us at Place, again, has been invaluable. And actually without that role and that partnership working between the police, the ICB and local authority, much of our local action plans for suicide prevention would fall down, because it allows us to instigate suicide cluster response plans. It allows us to work with schools very quickly when they've had deaths of children by suicide. As we've heard, it allows us to signpost to families of the suicide bereavement support in a timely manner. And it also allows us to be really on top of any public locations in our geographical areas. So without any of that information in a timely fashion, we'd just lose a lot of credibility to the work that we do at Place. So I just wanted to highlight some of that. So just moving on to a little bit about the work that we've been doing at Place. And obviously I work in Kirklees Local Authority, so I'm kind of speaking on behalf of Kirklees, but I am aware of lots of great work that my colleagues in the other 4 local authorities undertake. But we are committed to being data and intelligence led in what we do, and it's part of my role to share that intelligence with other partners, so that I'm trying to raise the profile of suicide prevention with other colleagues as part of that making it everybody's business. So there's 3 main things that we use to guide what we do locally. The first is the suicide audits. I'm really pleased to say that we've got good relationships with our coroners across West Yorkshire, and we've recently just undertaken a joint one with Kirklees, Calderdale and Bradford. And that relationship continues to go to be strong, and we're well supported by the coroner in the work that we do. They're really detailed, they're very in-depth, really privileged to have access to the coroner's files, and it's important that we do good with that work that we see and that we pull together to pull together the audit. The other bit of information is the real-time surveillance, and the third bit of information is what we hear locally from partners and from people that we work with lived experience. So we kind of triangulate those 3 pieces of information locally, and then we use those 3 bits of information to inform our suicide prevention action plan. But each of those bits of intelligence allows us to do something different. So we've got a proactive role at local authority level. So using any money that we can get our hands on from sort of grant funds, for example, to target areas of concern. So what we know through our suicide audit and that rich information, any grant funding that we get available, how can we channel that funding into the areas that we know we are seeing are high risk? But it also allows us to be reactive in terms of identifying any high-risk locations and initiating those suicide cluster response plans, which I've already mentioned. So generally speaking, across West Yorkshire, every local authority, we're all kind of set up quite similar, but we might call our meetings something different. But generally speaking, we've all either got an action plan and or a strategy. and it's informed by the National Suicide Prevention Strategy. So we try and keep it in line with what we know is in the national strategy. So things that have already been mentioned, we have going on at place. So we've got things around online harms and technology. We work closely with our media, which we've already mentioned. There's something called the Samaritans Online Harms Guidance and Media Guidelines, which we hold our media colleagues to account on. We've got a work stream around suicide bereavement. We have a work stream around high-risk locations, high-risk groups, and making suicide prevention everybody's business. So the action plans are very detailed and there's lots of great work going on. So again, one of the things that I would encourage is that if you are particularly affiliated to a particular local authority, please reach out to your local authority lead and find out and get involved in what they're doing and think about how your organisation can play their part. Just wanted to share before I pass on to just a few examples from our suicide audit of the rich data that we get. And so much of suicide prevention lies outside of sort of the medical side of things. I think it's really important that we don't over-medicalise suicide prevention or suicide. And so much of it is tied into how we live our lives and those wider social determinants of health. So from the Kirklees, Calderdale and Bradford suicide audit, for example, in the last audit, we know that 43% of people who died by suicide lived alone. We know that 65% had a diagnosed mental health condition. We know that 46% had a history of suicide attempt. We know that for 81% of people, their last recorded contact with services was in primary care. However, only 7% of those people disclosed self-harming or feeling suicidal at their last appointment. So there's something about encouraging people themselves to have the confidence to voice when they're struggling, but there's also something about encouraging services and making every contact count that I think we can improve on. And the other bit of information I wanted to share was that 22% of people that died in those 3 years, between 2019 and 2021, had at least one adverse childhood experience. And I know that's something Em's particularly involved in terms of the trauma angle. But, you know, that it's so important that things that happen to us in childhood, you know, can play out much later on in life. And just to echo the suicide bereavement services support that we give to children, that just shows how important that is, that if a young person has lost a child or parent or significant other to suicide, that support is there. So I'll pass on to Em to talk a little bit more. Thank you.
Thanks, Becky, and I just want to say another huge thank you to Ros and Rachel, particularly for stepping in at the last minute there, Rachel. Thank you so much for sharing your story. I just want to carry on from what Becky said and highlight some of the West Yorkshire achievements, but also what we want to do next. But also I want to highlight some of the latest drivers around suicide. So I don't know if anybody's been able to see or read the Woman of the North report, which is quite stark, around the life expectancy and how women are disproportionately affected across the north of England. And what we see is that there's a disproportionately number of women that, it's called in the report deaths of despair. Women taking their own lives. It may be related to substance use, alcohol, but often it's related to poverty, trauma and adversity, domestic violence, and lack of trauma-responsive gendered services. So there's a real link here, and we really need to see that link between adversity, trauma resilience and suicide prevention, not just for those that take their own lives and the people that are surviving, but also for the workforce that are supporting these families. And actually more and more at the minute, with the changes in the world and everything else that's going on, our workforce is really struggling, and we need to keep that in mind. So we need to ensure that we're supporting our first responders, our GPs and our mental health staff, as well as our voluntary community and social enterprise colleagues, because the vicarious trauma and the secondary trauma that they experience and the anxiety and that emotional exhaustion can lead to them having thoughts of suicide and taking their own lives. So just to build on some of the work that Becky's already mentioned, as well as the champions, we've got the Improving Population Health Fellowship, where we've just successfully recruited our third year of suicide prevention champions, health equity champions, adversity trauma resilience champions, and suicide prevention. They're people from our system that want to do more, that want to make a difference, want to be the change that they want to see, and they're out there helping us, and we're working with them with mentors and various other groups. We've also got the continued commissioning of the bereavement support service, and we want to keep that going. And hopefully we'll be able to continue to commission that till the end of March 2026, when the funding will again be needed to be looked for. We want to continue to embed lived experience. It's got to be at the heart of what we do. We cannot do this. I've not suffered a loss in this way. I haven't experienced trauma in this way, so I'm not always the best person to be leading this work. So we have to speak to our experts in the system, which are our people. And we want to do more targeted intervention. So Becky mentioned the Check-In with Your Mate campaign. This year we also run Check-In with Pride. So really targeting some of our specific population groups within the system. And we want to really challenge stigma. Stigma is huge, and it's not just stigma in relation to suicide prevention, stigma of obesity, stigma of adversity, trauma and resilience. It's all the same, and actually that's compounding the hurt and harm that people are experiencing. And we've also continued to support the commissioned post within HMP Leeds, which is around suicide prevention and trauma and adversity. And we've got a dedicated prison officer that's commissioned through the Improving Population Health Programme to support the workforce, and then that ripple effect will go down and support the men inside the prison. And they are an outlier for suicide prevention, so we do need to be able to support them in that way. The real-time surveillance we've covered. We really do need to keep that going, link it to the digital and data strategy of the ICB. And I want to really draw on the fact that we've trained over 1,000 colleagues now. I say we, that's the royal we. Kia Hamilton, our wonderful lead around workforce development, has trained over 1,000 colleagues. And we are one of the first ICBs to have it as a mandated item of training. And I think that's something to be celebrated. So moving forward, we want to look at how do we continue to build that capacity within the system? How do we expand the training? We're going to look at a training the trainer offer. We've just launched the Adversity Trauma Resilience Train the Trainer package, and Kia and Anna are going to be working together on that to deliver it across both programmes. We also want to look at how we strengthen the role of our suicide prevention champions, so that it's not just about giving a pledge, but actually we can see the action that's being undertaken and we can learn from that and share it. And then we want to continue to support our interventions at place, and how do we do that? And because, as Becky said, only 20% of what happens to us can be dealt with in the health and care system, and the rest of that has to be owned by the rest of West Yorkshire. So we also want to look at how we increase capability, continue to build the confidence and skills across all sectors, using peer-led models, embedding lived experience, and embedding the suicide prevention programme more aligned to the Adversity Trauma and Resilience programme. Those two go hand in hand and also sit with the inequalities agenda. We cannot separate those things out. And we want to look at how we improve, like I say, intelligence, not just the intelligence that comes from West Yorkshire Police, but also the intelligence from other partners that we're currently not gathering and we're not doing enough with. And there's intelligence coming out of that bereavement support service that's really rich, and we need to be building on that. So we've started to undertake a review and a refresh of the programme. The biggest change, I'd say, since this last came, and I think it was Richard James, my colleague that presented this last time, is in the funding. The funding, as Kim alluded to earlier, has ceased from region. So the funding now comes directly from the ICB and the funding that we get from SDF and various other places. So we really do need to think about how we do that across the system, because this has to be everybody, every sector's priority. And we all need to contribute to that. It's also about how do we keep the strength of our partnership alive in and amidst all the challenges. I've heard it said many times today, it's everybody's business but nobody's business, and how is it a priority within a whole host of priorities, and we need to keep it up there. And we need to look at how we align with the National Suicide Prevention Strategy, which I know Place do really, really well. So we're really well positioned in West Yorkshire to lead by example around this, and to provide that evidence-based, community-informed, linking into the neighbourhood health, integrated teams and the workforce accelerator to support people. So just to conclude today, we want to ask of the board to continue to engage with the partnership around suicide prevention across all sectors, with the champions, with the fellowship, with the website, to review options to mainstream some of the really successful work that's happening across that's currently short-term funded, and to look at those key interventions and services that we can scale up and perhaps do once, and to consider the approach that we need to take to ensure that we can address the limited and sustainable funding that we've currently got in the system. So it's everyone's business, as we've said, but we know that with your leadership, we can protect and sustain, we can grow what works, and we can, you know, for those that we've lost, we can still reach many of the people that are still at risk.
Thank you to you both. That's incredibly helpful. And as always, the documentation you provide is really helpful. Clearly why you're outlining this, why you're asking for it, and clearly for leaders in the room, the specific ask. So I think that's really helpful. I wanted to reference back to when we heard from Rachel and Ros, and I will say it as well, that importance of real-time surveillance, but then linking with the way in which we look at our intelligence, pool our intelligence and our digital strategy. And our new Chief Digital Information Officer, Shaukat Ali Khan, is with us today as well to hear that from you. Continuous and sustainable funding, which I'm going to ask Ian in a minute to respond on. And a reminder to colleagues in the room about the great campaigns that we have, and to promote those through their workforces and with their patient groups and service user groups. And also that point on suicide prevention training, I think it's incredibly important. I have it on my mandatory training list, and I encourage anyone that is working within a board where you're looking at things like mandatory training to make sure it's on your list as well. And are you still taking more champions if the people want to get involved? So there, I think it'd be great to have some more senior leaders involved in there. And that point that everyone in the room knows, but it's always a helpful reminder, valuing lived experience, because it means that the services we design and we implement and improve are always better and tailor-made. So Ian, can I just come to you from the commissioning point of view? Colleagues are continually concerned about how unsustainable funding is, and this is not a new thing. Kim Shuttler was talking about this before the break, about the concern, because we can see this as an important issue for everyone in the system.
Yeah, thanks, Cathy. And I think what we've seen nationally from NHS England is a sort of a collapsing of a lot of the sort of streams of SDF funding. So we used to get a lot of streams of funding with specific priorities and asks related to each of them. What we've got now is a kind of a bundle of funding that's been put into the baseline. To be fair to NHS England, we've always said give us more flexibility around how that funding can be used so that we can determine priorities and use it as we see fit. I think that there's therefore a choice for our partnership in terms of do we protect resources for this and continue to fund this work, which is clearly important. I think there's two kind of sort of the things I'd mentioned in that context really. Firstly, as everybody knows, the funding is hugely tight across health and care, and we are going to have to be really careful in our prioritisation. And secondly, it's that point in prioritisation. I think there's work for us to do off the back of the 10-year plan to really focus on the things we want to prioritise and get our weight behind those things, particularly in the context of the running cost reductions that we're going to go through. So I do believe we've got a choice as a partnership to continue to do this, but the financial context is increasingly challenging.
Ian, thank you for being open on that. I know we have a number of public health experts in the room today who try and guide us with data and information and intelligence that would guide us on how we, particularly in our role as within NHS West Yorkshire Integrated Care Board, the ICB is the commissioner for West Yorkshire of NHS services, that actually being population-led, population health-led, and meeting the needs of our residents, I'm sure will align with this. But as you say, this is an uncertain time for us as commissioners, and we're just waiting for further guidance to come through. Does anyone else want to comment at all? Khalid?
Thank you very much. We have spoken about suicide prevention. If it's everybody's business, just like safeguarding is everybody's business, suicide prevention is everybody's business. And then I think we still need to have some sort of a responsibility, shared. you said 83%, I think, people had contact, with the primary care clinicians prior to committing suicide. So this is something which gives a lot of information that's where we need to focus on. The only problem is that within primary care, clinicians have got only 10 minutes to go through, a consultation and finalize everything. And sometimes we don't have the luxury of time to actually explore more about their intentions, about their thoughts. And I think we need to utilize some other resources. Nowadays, we've got more and more mental health workers working through PCNs. In primary care, we need to probably emphasize more on some of those, and then having somebody to be, there for patients to be signposted so that they've got more time. There was sometimes something like half an hour to spend with the patient. So we need to work on these resources and have more of them. I know that there aren't very many mental health workers in primary care to tap into the resources not there, but we need to look at how we can make it possible for those resources to be available to primary care. Thank you.
Thank you. I'm going to just take a few more comments, and I think these are all really helpful suggestions, either for colleagues working specifically in suicide prevention or other colleagues working on things like integrated neighbourhood healthcare implementation, as well as within our place committee. So I think I've got Fatima and then Vicky and then Sean to come in. Would you introduce yourself? It just really helps people watching the meeting live or on record afterwards. Fatima.
Yeah, hello everyone. Fatima Khanshah, West Yorkshire Inclusivity Champion. So firstly, I just want to reaffirm the Mayor's commitment to have a follow-up conversation about this and to see what more we can do. I think the suggestion of aligning that proposal with the models of integrated neighbourhoods is an important one, but I also think it's about exploring what alternative models we can do to source revenue to create the infrastructure that everyone agrees we need. With that in mind, I wanted to probe a little bit more on some of the inequalities, because I can't help myself, as Em knows. So the first thing is, obviously, I'm proud to be the SRO for Inclusion Health, and we focus a lot on people that are with no fixed address or homelessness. And my sort of background reading when I was reading your report was that is a massive issue, that actually they really struggle to access services like this. So is there an opportunity for us to tap into that and see if there's more we could do? The other thing was, and I was really surprised, is that people that are living with a disability are also at high risk. I don't think we talk about that enough. And I wonder whether there's more we could do in that space. And then the additional thing is a real concern I have about the escalating risk as a result of people going into poverty and really financially struggling. And how can we, in a mitigation response to that, really support this infrastructure? Because actually prevention is better than, dealing with the consequences. There is some really great work that Young in COVID from Bradford have done in the context of people from diverse heritage talking about a subject matter that is really taboo. And as a Muslim Asian woman, we don't talk about this enough. And I do think we need to do more. So in addition to that, one of the things that I'm leading on for the Mayor of West Yorkshire is the multi-faith infrastructure that we've got in West Yorkshire and how we can use people of faith to really support suicide prevention. So I suppose there's a couple of questions in there, but also an offer of support.
Fatima, helpful as always. We're going to hear from Vicky, then Sean, and then we can come back to you and your reflections. Vicky, would you introduce yourself?
Thank you, Chair. Vicky Dutchburn, I nearly said director then, interim accountable officer for Kirklees Place. So the first thing I just want to say is, and people like Em and that will know, I am a real advocate of this because mental health is one of my passions and backgrounds. But I've got 4 key points that I just want to touch on. The first one is we touched at the beginning of the meeting about the changes and the reorganisation and restructure, and one of the key things that leads to suicide is loss of purpose. So I think there is something that as employers within our health and care system, we really need to take this on board and look at what are our, I suppose, support mechanisms that we've got in place just to make sure that people are fully aware. My next 3 are linked specifically to some of the asks on here. So I think this is a very specialist area and a very niche area, and I think we heard that from the patient's story. But I think there's a piece of work that we need to undertake about the generalist element of this. So there is something about how we raise that awareness, knowledge, ask the general questions, but also how we can then support the flow through the system. So there's people who will need the very specialist end of care, whether that's immediately or 2-3 years down the line, but also what are the other services and the way that we can use some of the more generalist services to support people and do some wraparound backwards and forwards, I suppose, is the way to do it. So I think we need to think about that, which will give us some efficiencies, maximise the capacity that we've got to be able to deliver this big programme of work. And then the other bit then links to the funding. And I think it is going to be one of those difficult decisions that we've got to take. We're going to have to work it through about how this is funded. We do talk about it being everybody's problem, but the only pot of funding we've talked about is SDF. So I just want to put that out there. So I think we've got to seriously think about that. And there is something about the prioritisation matrix that we use. So you could say that the numbers of people directly affected by suicide are quite small compared to maybe the number of hip replacements or something. Or on a locality level, they become small numbers. So what we've got to look at is actually what is the right prioritisation of this? Is this the impact or the benefits realisation of that wider impact, both socio-economic as well as to people's direct health? So I'm going to put that as a challenge to us collectively about how we do that prioritisation and keep it proportionate.
Vicky, that's really helpful. Thank you so much. I encourage exactly what you've outlined to be taken into place committee discussions, as well as the mental health, learning disability and autism provider collaborative as well, which then seamlessly moves over to Sean. And I thank you very much for that very pragmatic way of thinking about this, but it's how we bring it into the general ways of working as well. Sean, to you, if you'd introduce yourself, and then we're going to go to Robin.
Yeah, thank you. Sean Rayner from South West Yorkshire Partnerships Foundation Trust. Thank you for a very thorough report, and on paragraph 28 on page 7 talks about the suicide prevention action plan in each district, and from my experience that's a really important plan, certainly in our experience working across 3 districts in West Yorkshire. And to illustrate that, for example, at the Kirklees Mental Health Alliance, Becky attends routinely, provides an update on how the plan is progressing, and I think that gives traction to the plan's actions on a multi-agency basis, so that feels really important. I had a query, maybe not to answer now, but in the report I couldn't see where West Yorkshire compared against other equivalent metropolitan areas, whether we were an outlier or not, and whether there was any learning from other equivalent ICB. So just one maybe to take away. Thank you.
Thank you, that's really helpful. I can see Em's making notes as we go along, as I am, so we'll come back on that. And it is something that we do within our NHS West Yorkshire Integrated Care Board, which is more on your more classic NHS targets, but we do compare ourselves against other northern systems, particularly those in our North Eastern Yorkshire region. So that would be a fair way of sort of tracking our practice. However, what you're pushing us to do is improve our practice and our support and our ways of working, but I think it's a helpful benchmark. Robin, to you, would you introduce yourself?
Yeah, I'm Robin Tuddenham. I'm the Council Place Lead for Calderdale and Chief Exec of Calderdale Council, and thanks for all your hard work in this space. It's really important. You do highlight it in your action plan, but I just want to sort of make a plea, and I know this is well understood by you, but the role of the risk of suicide for men, and men at key points in their lives, and the challenge for young men. And I know there's a lot of national discussion about this right now because of adolescence and some of the dynamics for young men. I think in response to Sean's point, and I think West Yorkshire is probably towards the wrong end of this in terms of the data. I know Calderdale is the wrong end of this in terms of West Yorkshire, and I kind of see it as a kind of fundamental role for us as employers, both for our colleagues that we employ, but also people moving out of employment. I think the point about purpose is really important. And last week we held a day around Mental Health Day and Men's Health. I made 150 colleagues join an event to understand their own health and well-being, and it was actually led by our health and safety team. So I guess my offer is maybe, is there more work we can all do in the space of seeing this as a health and safety function, and being part of the core work of health and safety as an employer? And certainly we'd offer to help more in that space. Thank you.
Thank you so much, Robin. That's really helpful. Em and Rebecca, how would you like to respond to that? There's lots of offers of help. There's some ideas as well to you.
Yeah, just thank you for all the comments, suggestions and ideas. They're all very much welcomed. We've made lots of notes here. I'm not sure we're going to get through responses all today, but something that we can follow up on. But I just was going to pick up on the point about the primary care. So for Kirklees as an example, because of the results of the audit, we've prioritised primary care as one of our priorities for the next 12 months to strengthen that in Kirklees. So we are really looking for colleagues that we can work with in primary care, and we've got some, as it happens, some good examples of work that Calderdale and Leeds Local Authority have done in relation to their work on primary care. So we're not starting from scratch. We've got some examples from other areas in terms of what they've done as well. So I think that's just a really good example of the partnership working across West Yorkshire, is that we don't often start from scratch. More often than not, one of our areas has already started doing something, but definitely sort of open to doing more work in that area. So if you've got any ideas or people who you know would be interested, then I'd be really interested in hearing more about that.
Great, thank you very much. I think you've got at least 3 GPs in the room as I look around the room, so there's a good start.
Yeah, I don't think I'll get to answer all of these today, but what I can take away is the fact that we're doing the programme refresh as we speak, which means refreshing the strategy and make sure this is built into that, and we can bring that and share that virtually afterwards. But I think just to answer some of them directly, there is a massive need here to link this programme to adversity, trauma and resilience, because a lot of what you've talked about, poverty, purpose, mental health upstream, the prevention part of that is adversity, trauma and resilience, and understanding what's happened to people, intervening early and mitigating harm, so that we can look at how we can support people before they get to the point where they feel the only option is to take their own lives. And I apologise for any language that I might use that isn't, I'm still learning the language around suicide prevention. The other thing I think is absolutely around the segmentation of our population, how we understand where the risk is. We've done some work on that through the ATR programme around looking at groups that are impacted by inequalities, looking at groups that are impacted by suicide prevention and serious violence, and where the commonalities are. And there are lots of commonalities, and there are some very key groups, and young men, Robin, are absolutely one of those. I don't think adolescence is actually doing us any help at the minute, to be fair, in that space. And if anybody wants to know more, Kath Nibbs, who we work with, has done a really good piece around young boys in relation to that documentary. But I think there's something that we can do more in this space about understanding the specific needs and harms of those different population groups. No fixed abode doesn't just affect, people that are currently rough sleeping or those. It affects people leaving prison that often leave with no housing, no money and nowhere to go, and often leads back to prison. So there's so much more that we need to do and understand. And I think the beauty of this programme being sat in the Improving Population Health programme is our links with the other interdependent programmes across the system. Because I'm also thinking, Robin's talking about young men, I'm thinking physical activity in the MOU that we're looking at with Yorkshire Sport and Sport England. Physical activity as a protective factor is huge in this space, and we can do more, particularly around neurodiversity and those aspects. Multi-faith, I think, is a big one, Fatima. I did some work on this a long time ago, about 3 or 4 years ago, around adversity, trauma and resilience. I know that the Violence Reduction Partnership are also doing some faith work, and I think we need to build this in. And I think what we need to do is stop looking at these things in silos and bringing it all together. And Child First is another thing I know that the Mayor's championing, which is good in this space. I think, Vicky, coming back to your point about workforce, that is critical at the minute. I'm doing a weekly blog for the ICB with a trauma-responsive lens on the changes that we're going through as a workforce. And I think, and anybody that's seen me, I'm prolific on LinkedIn with that at the moment as well, because it's really important that we support our workforce. Just because we're functioning and we're working doesn't mean to say that underneath there's not a lot going on, and our own personal stories that we bring to the table of change. So I think there's so much more that can be done, but I think the fact that we've got this great system working with place, we can build on that and start to really look at that intelligence through the refresh. So my takeaway for you guys will be to pull that together and send you something back out in response to what you've raised today and the comments that you've made. Thank you.
Thank you. I thought we'd finished up on this item, but I think we've got some colleagues who want to come in. So we have got Susan and then Colin. If you would introduce yourself, I'd just ask you to be brief.
Hi, Susan Hinchcliffe, leader of Bradford. Just a broader point, really, sparking from this conversation. Obviously, this is really valuable work. There's lots of really valuable work going on, isn't there? And we know, obviously, the reorganisation of thing. I just think we all have to, in our own systems, get on top as quickly as possible of saying what the priorities are. And because it can't just be like, how do we take 50% of people out of here? We have to look at the whole system as a whole, because there's lots of valuable work going on all over the place. We need to prioritise that and say this needs to continue. But we need to get on with that work rather than just wait for some guidance. So I'm just looking for some reassurance that we're taking ownership ourselves, getting on with it, and getting ahead of the agenda before somebody tells us what to do. Because I always like being in charge of things rather than being told what to do.
And that was my point earlier about the fact that we have fantastic people from public health here who can guide us. Ian, do you want to briefly come in and then we'll go to Colin and then we'll finish up on this?
Yeah, I was going to pick this up a little bit under the Chief Exec's report. Just in response to Councillor Hinchcliffe's question stroke challenge, we are doing the work to rapidly kind of comprehensively review the way that we work as an ICB. In light of the announcements 2 weeks ago, we also have an eye on the guidance coming down because that will be important to respond to. So it's not a case of waiting, it's a case of cracking on and trying to influence what's coming down as well.
Yeah, great. Thank you. Colin, would you introduce yourself?
Hi everyone, I'm Colin Spears. I'm a GP in the room and Wakefield Medical Director for Integrated Community Services. It's just a note of caution. I welcome everything that's been done. I think it's an important area, but I always get twitchy when something is put forward for mandatory training. My experience is it's where good ideas go to die. Simply because if I think of all the mandatory training that is forced upon people, they don't engage in learning about it. And it would be, I think we need our colleagues across the NHS and care to want to engage in this area rather than be forced to tick a box as part of their mandatory training requirements.
Yeah,
Ian.
yeah, just to come back in on that, Colin, I agree with the general point that sometimes you've got the yes, no, click answers that you go through on a Friday afternoon if you've got a spare half hour, and that's not what this training's like. It's a session led by an expert. I think a lot of people in the ICB have been part of it. It's a morning-long session, and I genuinely found it really, really interesting and really valuable. So I agree with you that it can be kind of a lazy thing to say, well, actually, we'll do mandatory training to solve this problem. I don't think that's the approach that's been taken here, and I think that the session that's been led by Keir have been hugely valuable. I don't know if you want to come in.
Yeah, just to echo that, it's a face-to-face piece of training. So I can also say mandatory training, I would follow the same view there, but with this it's different. So we don't offer this online. This is face-to-face, and Kia has got a wealth. She's just doing an evaluation on it, actually, and she's got a wealth of feedback on how motivating and inspiring the training's been. And I think that's testament to Kia herself and the way that she delivers the training and that personal approach and that experience that she's got. It's the same with the adversity, trauma and resilience training and how we deliver that. But I'm always welcome to speak to people, and as is Kia, on how we can make that even better. I know that she's in conversations with primary care leads on how we can make that right for primary care, because it's not always easy to take a 3.5 hours out of your day to attend face-to-face training. We absolutely appreciate that. So we're looking at how we can make that offer just as impactful in different settings. But yeah, absolutely recognise what you're saying.
Great. Thank you so much. Colleagues, thank you very much for your thoughts, your ideas, your offers of help, your supportive challenge on this. I think it's incredibly helpful. And Rebecca, thank you so much. Before you go, I want to thank you, because this is my last partnership board meeting. Thank you for being my mentor in public health for my fellowship a little while ago. But for me, it helps me when we're having these kind of discussions. So thank you for your challenge to me, because as a leader, you're always learning as well. So yeah, I just want to thank you for that. But thanks for the presentation today. Really appreciate it. Thank you. Okay, we are going to move on to our next strategic item, where we're going to hear from Sarah and Sahel. So I want to invite them up, where we're looking at our ambition to increase years of life that people live in good health in West Yorkshire. And you've got a comprehensive report there, colleagues, looking at the progress that we're making against the recommendations from the board back in December 2023, and then looking ahead to the next few years. So I'm going to hand over to Sahel and Sarah to introduce themselves and introduce the document, and then really happy to take any questions or comments at all. So over to you. Welcome.
Thank you very much. I'm Sahel Abbas. I am a GP partner in Inner City Bradford, Deputy Medical Director for West Yorkshire ICB and West Yorkshire SRO for Health Inequalities.
Afternoon, everyone. My name's Sarah Smith. I'm Deputy Director for Population Health at West Yorkshire ICB and a consultant in public health.
Excellent. So I wrote a few points, and as you know, I'm a doctor. Now I'm having difficulty reading my own writing, but I will try my best. So we are going to, Sarah is going to talk about the details in the paper, but mainly there are 3 points we want to mention. One thing is about system working, and that is how the different parts of our system primarily responsible for things like wider determinants of health, our public health colleagues in terms of lifestyle factors and behavior, and bringing our ICB expertise in population health management, and real focus on health inequalities. This paper brings that system working in focus. The second thing is about the success of our equity-based resource allocation principles, and that is that in West Yorkshire, we wanted to gain the maximum benefit from targeting our very limited resources to the communities that are most in need, and this paper describes the success of that approach. And the third thing is about return on investment. And as NHS, there is a perception that when we put resources into health inequalities, it takes a lifetime to see any change. And while that is correct in different, such as working on the wider determinants of health, for example, but this paper shows that when we are targeting our people, our communities in need, with targeted interventions, we can actually see the dial moving quite quickly and reducing the gap in the health outcomes between population groups. So I will hand over to Sarah to take us through the paper.
Thank you, Sahel. And it was around 5 years ago, I think, we had this ambition signed off in this very building. And the same 5 years ago that Robin Tuddenham and James Thomas, as our SROs of Improving Population Health Functioners, was set up at the time, sort of kicked off the programme and kicked off this work. So it feels very poignant to be back here today discussing where we've got to with this ambition. At the time, the pandemic was just rearing its head, and we weren't kind of aware of the impact that was going to have. But when we talked about our 10 big ambitions, and we talked about setting health inequalities as one of those ambitions, and myself and the Director of Public Health in Leeds, and Cameron at the time, had a lot of discussion about what we should set for this metric. And actually, I think while the metric's important, as I would always say in public health, actually the message is just as important as having this as our first ambition for our health and care partnership. And I think what it's done is set us up as a leading ICB, or ICS as we were at the time, in the country, and it's a beacon really to show the commitment we have for being an equity-based system, and it's given the permission for us to do a lot of this work and have the focus. So I think we can be really proud of that fact. In terms of what we mean by the ambition, we talk about reducing the gap in life expectancy and the gap in healthy life expectancy, particularly in relation to deprivation. But within that, there's a lot of other factors, and factors such as intersectionality that we've considered over the last 5 years. An example of that being the review that we've undertaken with Professor Dame Donna Kinnair to look at the impact of inequalities and ethnicity as well. The ambition is a big ambition, and in order to break that down into some manageable chunks, and in order for us to take action as a system, what we discussed when we came back here in 2023 and gave a progress update was the building blocks that we've looked at to address this partnership ambition. So the building blocks in relation to determinants of health, so those factors that underpin good health, so where you live, the job you have, poverty, for example, the building blocks in relation to risk factors and protective factors and healthy behaviours, so things like smoking, alcohol, healthy weight, and then also the action we more directly take as a health and care system, so in terms of managing and supporting people living with long-term conditions. And then underpinning all of that, the leadership we have as a health and care system. So they were the areas that we discussed back in December 2023 when Helen and I came and gave an update. And this paper really focused on the progress that's been made since December 2023 and then our recommendations for next steps. So in terms of determinants of health, I'll take the paper as read, but I'm just going to pull out some of the key factors. In relation to determinants of health, we've touched a lot on the work and health agenda, and that's really key. And Fatima pulled out the focus on inequalities in relation to the work and health accelerator, which is very much embedded in there. But also importantly, in another way we've been leading the way nationally is our West Yorkshire Inclusion Health Unit. So these are people who are impacted by determinants of health, populations that are small in number and great in need, and a really good example of system working where we've come together and looked at these populations once across West Yorkshire, and the partnership that work there we've done with Leeds Gypsy and Traveller Exchange and improving health outcomes for that population. The work we've done over the last year, better understanding the needs of sex workers in West Yorkshire, the work we've done in partnership with Bevan Healthcare, and some real targeted work we're about to kick off with diagnosing respiratory ill health for street homeless population, and some great learning we've taken from Bradford and a health needs assessment for those cohorts as well. So that's a bit of a flavour of some of the work we've done on determinants of health. In relation to risk factors, a big focus for us to date has been tobacco. And in the last year, we set up the West Yorkshire Tobacco Alliance. Actions we've taken directly as a health and care system have been around our tobacco dependency services, which I think between April 2023 and October 2024 have seen over 17,500 people in West Yorkshire supported by that service, that have supported 690 people to quit. And that service has disproportionately targeted people in the most deprived quintile of our population. So it's doing the job in targeting and addressing inequalities through our health and care services. And that's something we've made a commitment to continuing to support with resource into 25-26. In relation to long-term conditions and support there as a system, last year we set a transformation priority related to targeted prevention. So targeting the long-term conditions that we know are contributing the most in relation to that gap in life expectancy. So cardiovascular disease remains a priority for us as a system, and we've got some examples of some really targeted community work we've done with sort of point of care testing where we can go out and work directly with communities and engaging people in discussions around their blood pressure or their blood cholesterol. And also work we've done on respiratory ill health as well, and really supporting people with earlier diagnosis, and that's something that we really need to continue into 25-26. So underpinning all of this, we mentioned in 2023 3 areas of focus for leadership, which I think are still really pertinent today, that relate to what Sahel touched on in the introduction around allocation, so how we allocate resources, advocacy, so our role as system leaders in advocating for health equity in our system, and accountability. And they're 3 areas we've made progress on again as a system in the last year. So in relation to advocacy, our population health fellowship, again, Kathy is an example of this, but over the last 3 years we've welcomed 140 population health fellows. And we calculated that actually for those fellows, that's totaled 37,800 hours of additional time on focused population health activities within our resource, and 1,680 hours of public health training that we've given across the system. And we've done that through partnership work. That's not additional, other than resource to VCSE, voluntary and community sector organisations for their time. There's no additional resource for that. That's done through partnership working and the release of people's time. So we've still advocated for that as a system. And we welcome Dame Donna Kinnair back. And that was, again, through us prioritising that as a system role. In terms of accountability, we have done, over the past year, 4 Health and Equalities Board deep dive sessions for our ICB board. So again, really welcome Kathy's leadership in that space and allowing that to happen. And we've taken a life course approach to understanding what the ICB's specific role is in addressing health inequalities. And we've done some more work on how we report to our ICB board as well. So we're looking at how our performance metrics contain measures around inequality. So we can say actually we're improving in this area, but also we're making targeted improvements as well, and that's really important, and that we're able to report that back to our board. In relation to allocation and how we allocate resource, we'll continue to make progress on this in relation to how we allocate something called our core 20+5 resource for health inequalities, and that's done in a targeted way. And we took a similar approach for how we allocated the work and health accelerator money. So £8 million of that money for targeted prevention was allocated based on the proportion of people who are unemployed due to ill health. So again, it's about targeting resource based on population need. So that's a bit of a flavour of the progress over the last 14 months. We've got some detailed next steps in the paper as well, which I'll leave you to read through. But again, centred around those determinants of health, links to the work that the NHS and the health and care system can take around poverty as a barrier to health, continuing work on our Work and Health Accelerator programme, and again, the work in all the health and all policy approach with the combined authority. In terms of protective factors, continue our work on the Tobacco Alliance, but also ramping up our approach to whole system work on obesity. In terms of secondary prevention, again, our targeted prevention work on cardiovascular disease and respiratory ill health is really important, but we need to improve and increase our intelligence function in order to identify the right cohorts. That's a recommendation we will make there. And again, in terms of leadership, I think what we're asking is that continued commitment to advocate for health equity through these changes. So as a strategic commissioning function, what is our role around health equity? How can we really embed that in all we do? And how can we see that come through in the way we allocate resource and the way we lead our system through these health and care changes? So back to Sahil.
Thank you. So in terms of our messages to the partnership, essentially, broadly speaking, there are three messages we want to give. Our first message, and I'm going to use the words of my mentor and boss, Helen Hurst, who is present in this room. As a health system, when it comes to our work on health inequalities, there are things we can do, there are things we can influence, and there are things we can control. And as a health system, it's unforgivable if we do not do the things that we can control. And that is so true. Working on health inequalities, there is not just a moral or ethical case. There is an economical case, as we have just heard, of if we can support our people and get them back into work, that would be a huge boost to our economy. There is a financial case because we know that in the next 10 to 15 years, there will be about 20% increase in people living with multiple long-term conditions, and 50 to 60% of that increase will be in areas of highest deprivation. So if as NHS we want to survive, the work on health inequalities has to move permanently from the nice to do box to a must do thing. So that is our first message. The second message is that what you have heard is a result of using 0.1% of our total allocation as a health and care system. So how would the world look like if we use these principles to allocate and use the totality of our resource? And that is the foundation of making a value-based health system. And our main message and our recommendation is, as Councillor Hinchcliffe said, future is uncertain, but the best way to predict the future is to shape it. So what we are saying is that we recommend that the universal element of continuing to improve health of our population as a whole and the proportionate element of targeting communities in greatest need should be at the heart of our planning to become the strategic commissioner. Thank you.
Thank you to you both. That's really, really helpful and very powerful. And Sahil, I invite you to write those 3 points down, and we need to do a follow-up from this meeting for lots of reasons, so we can include that in the follow-up because we know some colleagues couldn't make us today. So thank you so much. And that's a challenge to us as well as leaders of a commissioning body as well. Would anyone like to respond? I'm quite interested. I was thinking from a governance term as well. I know we have tackling health inequalities, for example, in our board assurance framework. for the ICB board, which is what led me to commission the life course approach, which Sarah, you put together for us as an ICB board to understand what our role was in tackling health inequalities and reducing them. And so for those of you who are parts of boards, whether it's Place Committee, Health and Wellbeing Board and NHS Provider Board, I really encourage you to have that within your board assurance framework as well, to make sure you understand how you are mitigating the risks and playing your role in reducing health inequalities. We'll go to Susan, then we'll go to Fatima. Thank you.
Yeah, obviously I agree with a lot of what Sahil said. Then obviously he's my vice chair on the Health and Wellbeing Board, so we do agree with each other. I think it goes back to my previous point about how do we refashion the health system to make sure that we take into consideration what is going to impact us positively in the long term, because we can't just keep being reactive, can we? It's very expensive and it's not turning the curve. So with this, we have to see everything as an opportunity. And the opportunity is to say how to remodel things, to make sure some of the learning we've got here, and actually Bradford's got a load of learning in it. There's a load of researchers all over Bradford. We need to pick up what have they discovered that is going to make a biggest difference, and then we fund that, and we stop them looking at other little things that might not be quite as impactful. So we need to all focus really quickly on what is going to make the most difference, and then fund that, because I think there's lots of learning now, isn't there, with the RICS programme, born in Bradford, and obviously other authorities have got their own learning that we really need to now start putting in place. So let's not start with what we've got, but start with what we really need to do and start with there. I think the only thing I mentioned is there was an awful lot of reference to children in there, and obviously I know that's a long game as well when it comes to children, making a difference in children's lives. But you know, this is the week after with the child poverty statistics that come out, and 44.1% of children in Bradford live in poverty, which is appalling. And therefore we have to address issues like that. I know obviously there's a lot of work going on with children anyway in Bradford, and you can't resolve novelists can just resolve child poverty all of a sudden, but it does have a direct impact on all the health system. So it's just a sort of plea for all of us to come back, including GPs, you know, as part of one system, and not just fighting for our own bit. You know, GPs, hospitals, councils, all coming together to get the right solution. Thank you.
Thank you. I have Fatima, then Jen. Fatima.
Shockingly, I agree with both Councillor Hinchcliffe and Dr Abbas. Shock horror for everybody. A couple of reflections and then maybe a suggestion as well. So firstly, I really think the cost-benefit analysis that you talked about, it really adds value, and I don't think we talk about equity in terms of money, and I think we need to start to. So I really think we need to really think about that. I know that the social and moral reasons should be sufficient, but in my line of work I've learned it's important to talk about the cold hard cash as well. I really appreciate the synergy, Sarah, in regards to our equity and fairness strategy and the work on health inequalities, and I think as we move forward to strategic commissioning we need to strengthen that. I think we need to call out this wokist conversation about equity and doing the right thing as some sort of populist thing, when actually it's, you know, as Rob would say, barn door obvious that we should do it, and we should, you know, face that challenge quite openly and honestly. I think the thing I would say though is we need a call to action to our leadership to do the right thing rather than what's popular. And I think when we're talking about the difficult decisions element in particular, I think the cost-benefit analysis and the equities data needs to be embedded in the difficult decisions framework that we've got in all of our organisations. Now, I've learned in my line of work to not assume people do that, and I wonder whether there's something to strengthen Sahil's three-point narrative to make sure that that is something that people routinely do, so that, as you know, Councillor Hinch has alluded to, we're focusing our efforts on the area of maximum value, and that might require us to take some unpopular decisions, but that's what courageous leadership looks like. I also think, for the record, that Sahil is wasted as a GP and should really think about politics, but that's a different conversation.
I would say, though, we do need GPs. I think we've got Jen, sorry, and Helen, do you want to come in? No, we can bring you in, and then Karen wants to come in. Sorry, there was something else I was trying to communicate to you, Helen, as well, at the time. Jen, then Helen, then Karen.
Thank you. Jen Connolly, Associate Director for Improving Population Health. I work jointly between the West Yorkshire Integrated Care Board and the West Yorkshire Combined Authority. And with that in mind, I just wanted to highlight that in relation to the determinants of health piece, we've been part of a mayoral regions programme that's funded through the Health Foundation, and last week launched a Health in All Policies toolkit for combined authorities. We'll share that around after the meeting, because I think there's much of that is relatable to many different organisations as well, but that's taking that health in all policies approach, and it's kind of a 4-step toolkit to work through that maturity of embedding health thinking and outcomes in the different work of different policies and so on in development. So I think just something to add to the sort of suite of tools that's available to us in helping embrace and increase our focus on determinants of health as well. Thank you.
Thank you, Jen. Then we'll go to Helen, who was referenced by Sahel, then Karen, and I'm also making a list on the follow-up we have from this meeting as well. Helen.
Yeah, thank you, Sahel. So I'm Helen Hurst. I'm chair at Calderdale and Huddersfield NHS Foundation Trust. A couple of points. As a Foundation Trust board, I was very surprised when I joined it to find how much of the airtime was being spent on discussing health inequalities, and that's only increased, I would say, over my first 3 years there. So I think when it comes to the do what you can do, then I think certainly I've seen that in action within the context of an NHS trust. My second point was, if this isn't core and central to what an ICB does in the future, I don't know what is.
Thank you. Yes, and it comes back to the work we're already doing on defining strategic commissioning for ourselves, as well as waiting for national guidance to in turn then influence that as well. And I know we had a good chairs discussion. Some of us gathered this morning, bringing board chairs together, and we had a wide-ranging discussion on best practice that we could draw upon in recent times as well as in the past. And we keep coming back to world-class commissioning, which I know our colleagues in public health are looking at the moment as well, and coming back to. Thank you, Helen. That's really helpful and a good example of how an NHS trust board in our system, and we have 10 of them, is working on health inequalities at the moment as well. And then to Karen.
Thank you. Karen Jackson, Chief Exec at Locala and Sector Lead for Community Services. So as a member of the DARSI expert panel, this is absolutely central to the findings and the outcomes of that. So I'm a bit with Helen on, if this is not the thing we're focused on, then I'm not quite sure what is. And it's a challenge I've often put in the room about the left shift, and beyond just into communities and where people live, but actually into the preventative and health and well-being generation space. So not simply about the preventative piece, but the actual support for people to live healthy lives. I think the other thing I'd say in that space is this is not just a role for statutory bodies. This is the sweet spot where voluntary sector, social enterprise, lives and makes an enormous difference to people because they actually understand people where they live. So I would say that that's really important to make sure we don't just make this a statutory body conversation. And also, it's important we involve the people in this space. Those individuals who are living with these issues and challenges know the solutions. So please can we make sure that when we design, we involve everybody. Fabulous, thank you.
Thank you. Sahel and Sarah, do you want to just reflect on that before we finish up?
Yeah, I think I would just like to say that as West Yorkshire Health and Care System, we should be proud of the work we have done and we are doing. We are pioneering the work on health inequalities, and that is, that is recognized nationally. And that is the work of our teams, people like Em and Sarah and everyone, all our teams in the region and our places. I think that was phase one. We have done a lot of learning. We have done lots of stuff. I think now is the time to move to phase two, which is the strategic commissioning. And that is to make this way of working the way of working, because essentially we just do not have an other option if we want to survive. So thank you very much for the continuing support.
Yeah, I'll come in on the practical after Sahel's done the motivational, and that's why we work well together. Just a couple of practical points. I think And just to give you some reassurance, Councillor Hinchcliffe, on the children and young people's point, I think there are some principles in here that read across the children and young people, but there's also a dedicated partnership ambition on the children and young people's work, so we will be able to cover that partnership board at some point, and we covered some real good specific elements as part of the deep dive work on childhood asthma and mental health, as well as some specific areas. So I just wanted to make that explicit as well. And I think something that maybe I don't touch on enough in, but was in the paper, but maybe not as explicit, around the service review, and it was just to Helen's point around Colesdale and Huddersfield Foundation Trust, but also the other pockets of excellence we've got of health and equalities leaders within our organisations. I think the fellowship's drawn some of that out, but we've got some real good system leaders, and I think we need to continue to draw that out as part of the services review and make it really, really practical. The approaches we're doing, and make it kind of linked to Sahel's point around value. So health inequalities isn't something that's over here, it's something that's embedded in our approach to kind of value-based systems going forward. And you say we've got some excellent pockets. And just another toolkit plug that I'll share around, we've got a poverty toolkit, and it's Public Health Registrar working in your trust, Helen, and she's done a fantastic NHS poverty toolkit, which we can share around as well.
Sahel and Sarah, thank you so much. I've got as our follow-up letter to all members of the Partnership Board the 3 points from Sahel, a reminder of all the tools that are available to colleagues in their leadership roles and the boards that they're part of as well. And thank you for continuing the Population Health Fellowship Programme. I greatly benefited from it, and I appreciate your challenge to us as leaders, which the hell you did right when I started my Population Health Fellowship, when you said, how are you going to work with the Mayor? And I hope you saw an example of that today with Mayor Braben joining us. So thank you very much, and thank you for also not only being challenging, but helpful and supportive to leaders in our system as well. Thank you. Great. We're going to finish the meeting at 4:30. We've got one item left on our agenda today, which is to receive the Partnerships Lead Chief Exec report, which Ian Holmes is going to give an overview for in deputising for Rob Webster today, and then we can take any questions. So over to you, Ian. Thank you.
Yeah, thanks, Cathy. Hi, everyone. Ian Holmes, Director of Strategy and Partnerships and Deputy Chief Executive for the ICB. So there's an awful lot going on at the minute, and what we've done is we've produced a short paper for the Partnership Board, as well as Cathy and Rob's paper that was taken to the ICB Board 2 weeks ago, which provides more detail. 3 or 4 things I just want to cover briefly before we open it up to questions. The first one, I just want to mention the running cost reductions announcement of 2 or 3 weeks ago. So there was a flurry of announcements, like I say, about 2 or 3 weeks ago, which will affect kind of the health system fairly profoundly, I would say. The first one was that there was it was announced that NHS England would be disestablished as an organisation. So it will be disestablished under primary legislation, and the functions will be taken on by the Department of Health and Social Care. Alongside that, there's a fairly eye-watering running cost reduction for ICBs of 50% by Q3 this year. NHS England 50% by Q3 this year, as well as comparable sort of reductions in provider collaboratives and operational delivery networks. The other thing that we haven't touched on today, but which is also quite important, is that there's been a fairly sweeping change of the leadership of NHS England. So Chair, Chief Executive and most of the Executive Directors of NHS England are leaving imminently. And we've got a new Chief Executive, Jim Mackey, who starts today, and a new Chair, Penny Dash, who's starting as well. And that will change how it feels and what the immediate period will feel like working with NHS England. As we've said, there's no further detail on the on those kind of running cost reductions, running cost and programme cost reductions, how they will be applied. And we are expecting further information from NHS England around future functions of an ICB, but as Councillor Hinchcliffe reminds us, we're not waiting for that information, but we are expecting it. The other thing that you might have seen in the news today was conversations about a big consolidation of ICBs, so the idea that you'll move to less than 42 ICBs, which there are currently. I think this reflects that the variance of size is from about 500,000 at the smallest to about 3 million at the biggest in terms of population. We're the fourth biggest of the 42 ICBs. So we're not expecting that consolidation to affect West Yorkshire. We've not had any conversations at this point around a move towards that, and we think the impact on that is more likely to be further south, where you've got a lot smaller ICBs. Needless to say, it's been quite a challenging time for staff, quite a concerning time for staff, and I think the way that the announcements came out and then nothing immediately following that probably hasn't helped with that. So as I mentioned earlier, we're undertaking a rapid review to comprehensively review what we do as an organisation in line with the kind of some of the sort of thinking around strategic commissioning. Clearly the work on health equity, health inequalities will be a fundamental part of that. That won't be lost. And in parallel with that, we're working with partners to understand what needs to be done by the ICB and what can be done through partnership arrangements. Partnerships are really, really important at this time. Staff received lots of really kind messages from people across the partnership when the announcement came out, and that was really, really appreciated by staff. And clearly, as we're developing models for how this will work in the future, we will engage and work with partners across the system in doing so. We're communicating regularly. We're communicating weekly to ICB teams to share anything that we've got in terms of updates. We've got weekly staff briefings. We've also got a partnership communication, which is coming out weekly as well, so that we're all working on off the same basis of information. We're expecting a letter may land today from the Chief Executive of NHS England on his first day, which may provide further information for us to work with as we develop our plans. Final thing I'd say is that we are seen as a mature, well-organised partnership that delivers. We've got quite a lot of lines into the national team, and we'll continue to use those to advocate for West Yorkshire and try and influence this process as positively as we can, recognising that there's a political reality to the changes that I think we're about to embark on. So I just wanted to say that in terms of the running cost and programme cost reductions work, and we will continue to work closely with partners on that. The second thing I just want to mention briefly is that we are now getting to the end of a challenging planning process, and we are in the process of finalising the plans which will deliver a balanced financial plan overall for West Yorkshire ICBs, recognising that some organisations are more challenged than others, a set of workforce plans which show a slight reduction in the overall workforce with bigger reductions in bank and agency staff, and a set of plans that demonstrate compliance with national performance targets. So it's a broadly compliant plan in very difficult circumstances, and again a huge amount of work has happened across partners, across people in this room to get those plans into this place. It goes without saying that there's a lot of risk within that plan, particularly around delivery of the money, particularly around delivering those workforce reductions safely, and the running cost announcement from 2 weeks ago will clearly add risk into that, and we've been clear with NHS England that there's additional risks now as part of that announcement. Third thing I just want to mention briefly is that at the January meeting we talked about our equity and fairness strategy, and we asked all partners to write back to us describing how they were going to prioritise this in the immediate term. That is a small piece of work, not a big piece of work that we're asking for you all. I know that we asked that at a time that was really, really busy for the system, but we'll go back out with that ask, and hopefully you'll be able to come back and share what you're doing on that. Some have replied, which is great, and some haven't yet, but if we can get more responses to that, that would be fantastic. And the final thing, just to mention briefly that it is Cathy's last meeting of the Partnership Board. She's been with the Partnership for at least 5 years, starting at Bradford District Care Trust, then as the chair of the ICB. Always been a really positive and energetic voice within the partnership, and a real sort of force for good in the partnership, and she's always worked really hard to advocate nationally for our system and the way that we do things here. So she'll be really missed, and we wish you best for your time in Cheshire and Mersey, Cathy. So I'll pause there. Thank you.
That's good of you. Thank you. Thank you very much, Ian. That was really helpful. Susan.
obviously it's a big subject, isn't it? It's NHS reorganisation, so I won't spend a lot of time talking about that. It's just obviously I always speak positive about West Yorkshire Partnership when outside West Yorkshire as well, so I think we do work well together. Obviously there's challenges, we all know those, and I'm hoping that we get through this latest challenge into a positive way, so we serve the people of West Yorkshire to the best of our ability, as I know we all intend to do. I just wanted to say thank you, Cathy, on behalf of the leaders of West Yorkshire, because obviously you've worked in Bradford a bit as well, and you're a very good chair, you're very on it, you're very efficient, you know your stuff, and we will miss you from the system. So just from us, wish you well in the future, and thank you for all your hard work and all your service to the people of West Yorkshire, and indeed, of course, to Bradford, at which point I need to go to a train.
Susan, thank you very much. I really appreciate that. But as you know, Susan, I will continue to lobby and campaign for the communities of the north of England, and I'm sure our paths will cross in future with everybody in this room and our partnership as we continue to do that together. So thank you, it's kind of you. Does anyone have any questions or comments? We've got quite a lot of information that both Ian has given an overview on, and we've got Rob's report and my report. I hope you find the information helpful. I wanted to highlight with you at the ICB, the NHS West Yorkshire ICB board meeting 2 weeks ago, we looked at reducing health inequalities through maternity services. We had some great discussion around that, including setting up an AI working group to support maternity services, which I thought was a great result out of that session. And then the next NHS West Yorkshire board meeting in June will then have an overview of NHS maternity services within the system. And I think it's more for those who are working with elected officials. I'm thinking health and wellbeing board chairs who may find those kind of reports really helpful, as well as colleagues working in the NHS. So that's something I want to flag. And thank you, Sarah, again for taking that brief when I said, can we work on this? And you have done that over 12 months for me, which is fantastic. Is there any other questions or comments at all? I hope it's helpful to receive those reports. Yeah. Okay, I think there's another point as we go through change. We need to keep communicating, which is what we're aiming to do. We thank Rob Webster in his absence for coming out of a national meeting in London on the 13th of March and half an hour later sat somewhere randomly in a venue in London running an all-staff briefing for our NHS West Yorkshire ICB staff. I think I've heard people today saying how helpful that was, and I know he's doing his best at the moment, and we're keeping partners informed. There's always change in health and care, there's always change in the NHS, but we just want to navigate it in a considered and respectful way, which we very much recognise. Okay. It leaves me then to say this is the end of the meeting. Our next gathering is via Teams. We're having a virtual meeting of the Integrated Care Partnership on the 15th of July. Anyone who would like to submit a question in advance, that will be on the 14th of July. It will be chaired by our Integrated Care Partnership Chair, Councillor Hinchcliffe. As you know, he's very sadly had a family bereavement, and our thoughts are with him and his family at the moment. But we hope he'll be back and working with us again in July. By then, there will be an acting chair for NHS West Yorkshire Integrated Care Board, but hopefully through the recruitment process, you will know who the next chair of the Integrated Care Board is, as well as therefore the deputy chair of this partnership. And it is my last meeting. It has been a privilege to be part of this system. And it was a bit bewildering as I sat over there when my second partnership meeting 5 years ago and getting to know you all and the ways of working. But it is a fabulous system. It should be greatly proud. And Sahel, I think you reflected earlier, we do a great job. We're making great progress. But the other thing we do is we're restless for improvement all the time, which is what your challenge and others are to us today. So take confidence in that. And I'm going to stay in touch because we've all got a lot more work to do across the whole of the north of England. So take good care. Thank you so much for your time today. For colleagues who are unable to join us, we will do a follow-up, but we'll also send a follow-up to you as well, so you've got a note and reference to take back to your organisations. And thank you for all you're doing at the moment as health and care leaders. Safe travels. Thank you very much. That is the end of our meeting.